Stroke Ready Hospital, our fast response neurological team and ambulance are always at your hand. Powered by artificial intelligence driven 1,5 Tesla MRI RTPA injection, DSA catheterization, microneurosurgery, comprehensive stroke rehabilitation, and home care services, we are committed to ensure your healing process. Our orthopedic and trauma center is adept at handling sports injuries with precision and minimal trauma. From rapid emergency response, advanced imaging, complete operating theaters, arthroscopy, to professional rehabilitation programs. Trusted by international sports organizations such as FIFA, AFF, and IBL, we support your comeback and your determination to become a champion. Enhanced by a green environment, spacious treatment rooms, and natural sunlight, we strive for your optimal recovery. Indriati Hospital, trust, professionalism, and compassionate care. Indriati Hospital, we work for a healthier Indonesia.
Yes, we work for a healthier Indonesia. And that's a company profile video of Indriati Hospital. We now come to the opening remarks session, and it's our great honor to welcome Dr. Anthony Halim Gunawan Mars Vesqua as the director of Indriati Hospital to deliver the opening speech for today's International Oncology Webinar. We truly appreciate his support and commitment in advancing healthcare innovation, international collaboration, and patient-centered care. Mari kita sambut untuk Direktur Rumah Sakit Indriati Solo Baru. Selamat pagi, Dr. Anthony.
Halo, good morning.
Selamat pagi, dokter. Kami persilahkan pagi ini mungkin untuk menyampaikan sambutan sekaligus membuka webinar pada pagi hari.
Okay, thank you, Dr. Novi. Distinguished speakers, honored guests, respected colleagues, ladies and gentlemen, good morning and welcome to the International Oncology Webinar, advancing into the new step of cancer treatment, integrating international innovation into local clinical excellence. It's great honor for me as the newly appointed director of RS Indriati Solo to open this important scientific forum today. Cancer care, as we know, cancer care is entering transformation era. Rapid advancement in the precision medicine, chemotherapy, early detection, digital health, and multidisciplinary treatment approach are redefining how we serve our patients. In this evolving landscape, international collaboration is no longer optional. It is essential. Today's webinar reflects our set commitment to improving oncology service through knowledge exchange, innovation, and global partnership. We are especially proud to collaborate with Fosun Group Hospital, whose expertise and experience contribute significantly to the advancement of modern healthcare and cancer treatment. This initiative is also aligned with the strategic direction of the Indonesian Ministry of Health in strengthening referral healthcare services through of the KJSU program. KJSU is cardiology, cancer, stroke, and uronephrology as national healthcare priorities. As one of the key pillars with KJSU service, oncology requires continuous improvement in clinical capability, technology adoption, research collaboration, and human resource development. Through this webinar, I believe, and international collaboration, we hope to support the Ministry of Health vision by accelerating the transfer of knowledge, enhancing clinical excellence, and expanding access to high-quality cancer treatment for our communities. We believe that integrating international innovation with strong local implementation will help create a more comprehensive, patient-centered, and sustainable oncology service in Indonesia. I would like to express my sincere appreciation to all distinguished speakers, moderators, healthcare professionals, and participants joining us from various institutions and countries. Your presence demonstrates our collective dedication to advancing cancer care and improving patient outcomes. May this webinar become valuable platforming for learning, collaboration, and inspiration, leading us toward a future where cancer treatment is more precise, accessible, and compassionate. Thank you once again for your appreciation. I wish everyone productive and insightful webinar. Thank you very much.
Okay, thank you, Doctor, for the wonderful speaking today to opening our webinar. And ladies and gentlemen, the next agenda is the company profile video presentation of Fosun Hospital China. Through this video, we will get a closer look of Fosun Hospital's healthcare services, medical innovation, global collaboration, and commitment to advancing patient-centered care. To the audio-visual team, please play the company profile video of Fosun Hospital China. Video, please.
First, treating patients like family, prioritizing virtue, pursuing excellence, friendliness, appropriateness, caring, and service. Fosun Chongqing Hospital has always adhered to this service philosophy, fully leveraging the courage and responsibility of its reformers. Daring to explore and innovate, the hospital has recruited top talent and made tireless efforts to improve access to healthcare and sense of happiness for the people in the Greater Bay Area. The Orthopedic Center, consisting of 5 subspecialties: spinal surgery, joint surgery, trauma orthopedics, hand surgery, and sports medicine, utilizes 3D printing and artificial intelligence to accomplish various complex surgeries for anatomical deformities of the atlantoaxial vertebra. Working with the neurosurgery department, the center has successfully performed intraspinal tumor surgeries in the upper cervical spine, rising to the biggest challenge of orthopedic surgeries. The Spinal Orthopedics Department has been designated by health authorities as the strongest hospital department in Guangdong several times. The Precision Oncology Center, a member of the Radiosurgery Society, offers diagnostic and treatment services such as genetic testing, genetic counseling, and international multidisciplinary consultations. With the introduction of Fosun's first M6 cyberknife and multiple new technologies, such as CAR T-cell therapy and electric field therapy, the center provides patients with cutting-edge, precise, and standardized treatment based on the principles of full-cycle management, one-stop service, personalization, standardization, and precise diagnosis and treatment. The Surgical Center has extensive experience in the diagnosis and treatment of common surgical diseases, perioperative treatment and management of major surgical operations, as well as consultation, diagnosis, and treatment of tumors and complex surgical cases. It has developed the technical expertise focusing on minimally invasive surgery, ultrasound guidance, and rapid rehabilitation with the introduction of the next-generation surgical robots. It has led the country in innovative surgeries such as fluorescence laparoscopy, laparoscope pancreaticodenty, cervical thoracic abdominal 3-incision radical surgery for esophageal cancer, and free greater omentum transplantation for breast reconstruction. Collaborating with Professor Wang Jian, chairman of the Chinese Urological Association, the hospital is making new breakthroughs in the field of minimally invasive urological tumor surgeries. The Women's and Children's Center has introduced advanced technologies and management practices at home and abroad, and capitalized on a high-end perinatal medicine center, a well-equipped gynecological center with strong expertise, and a comprehensive pediatric center to make itself a center with both excellent hardware and treatment-centered core competency. A full life cycle healthcare management platform for perinatal and general women's and children's health is provided for specialties with different dimensions. The Heart Center is a major cardiovascular disease prevention and treatment center in Chongqing District, Fosun. It is a Fosun 14th Five-Year Plan key clinical specialty and is a national 5-center certification unit. In terms of technological breakthroughs, the center has successfully performed challenging procedures such as pulsed field ablation, renal denervation, closure of patent ductus arteriosus, transcatheter aortic valve replacement, and mitral transcatheter edge-to-edge repair. The Traditional Chinese Medicine Center brings together famous TCM experts from across the country and consists of clinical departments such as National TCM Practitioners Center, TCM Department, Department of Integrated Traditional Chinese and Western Medicine, and Rehabilitation Medicine Department. It offers distinctive TCM services that incorporate disease diagnosis and treatment, scientific research and teaching, and comprehensive health management. Big Health Promotion Center. The hospital has built a Big Health Promotion Center to support the Healthy China national strategy. Consisting of the Alma Laser Aesthetic Center, Health Management Center, and Yulan Health Club Premium Medical Center, it is committed to creating a new full life cycle health promotion model for families. The Promotion Center provides high-quality laser cosmetology services with advanced laser equipment and technology. The Promotion Center has also achieved significant success in reducing cardiovascular and cerebrovascular diseases by 70% with advanced blood purification equipment from Asahi Kasei Corporation. Foshan Fosun Changcheng Hospital focuses on clinical service, scientific research and teaching. As the first designated healthcare facility to implement the Hong Kong and Macau Medicine and Equipment Connect policy in Foshan, the hospital has taken the lead in introducing a variety of novel medications and devices of international repute, and it has applied many precise and cutting-edge medical technologies from other parts of China and foreign countries in Foshan to benefit the general public. Today, the hospital's laboratory has obtained ISO 15189 Quality Management System certification, demonstrating its internationally standardized testing capabilities. It has also innovatively introduced services such as Changcheng Hospital at Home, nursing home visits and specialized nursing outpatient clinics. Building on tradition and pursuing innovation in the context of healthcare's high-quality development, Foshan Fosun Changcheng Hospital has ranked first among non-public hospitals in China for many years by virtue of its great strength. The distinctive services that it has developed through innovation in response to the needs of the times will contribute to the creation of a new healthcare hub in the Greater Bay Area.
Okay, what a wonderful videos. And ladies and gentlemen, we're now honored to invite Mr. Seng Yan as a Fosun Global Partner, Co-President, Chief Strategy Officer of Fosun Health Group, General Manager of Fosun Insurance Ecosystem Business, and International Cooperation to deliver the opening speech. Good morning, Mr. Seng Yan.
Good morning. Good morning, Hi. Yeah.
Hello,
Thank
it's
you,
really an
Dr.
honor
Novi.
to have you joining us today.
Okay.
So, Mr. Yan, the time is yours to give an opening speech.
Okay, sure. It's my pleasure. And good morning, distinguished guests, doctors, colleagues, and friends from Indonesia and China. First of all, on behalf of Fosun Health, I'd like to express my sincere appreciation to us Indriati for organizing today's International Oncology Webinar together with us. It is a great pleasure to join this meaningful academic exchange between IS Indriati and Fosun Health. IS Indriati is an important sister hospital partner of Fosun Health Greater Bay Area General Hospital, and we highly value this collaboration. Cancer treatment is becoming more complex and more integrated. Today, no single hospital or single specialty can solve all problems alone. We need stronger collaboration among surgeons, radiation oncologists, medical oncologists, imaging specialists, nuclear medicine experts, interventional doctors, nurses, and many other professionals. This is also why today's webinar is so important. Through this platform, we are not only sharing technologies such as precision radiotherapy, CyberKnife, CAR-T therapy, and integrated cancer management. More importantly, we hope to build a practical bridge between doctors in Indonesia and China. For Fosun Health, our goal is very clear. We want to support our partners with high-quality medical resources, advanced clinical experience, and a reliable patient referral pathway. For complex cancer cases, we hope doctors from both sides can discuss earlier, evaluate together, and help patients find the most suitable treatment options, and hence the more opportunities for long survival and better life quality. Fosun Health Greater Bay Area General Hospital, with Foshan Fosun Chancheng Hospital, as our flagship hospital, has been developing strong capabilities in oncology, radiotherapy, surgery, interventional retreatment, rehabilitation, and international patient services. We are very willing to share our experience with IS Intriati and Indonesian medical professionals. Today is only the beginning. Going forward, we look forward to more regular academic exchanges, case discussions, doctors training, hospital visits, and patient education programs. We believe this collaboration can bring real value to doctors, hospitals, and most importantly, to patients and their families. Finally, I would like to thank IS Indriati, all speakers, and all participants for your support. I wish today's webinar a great success and look forward to deeper cooperation between IS Indriati and Fosun Health. Thank you.
Okay, thank you very much, Mr. Shanyan,
Thank
for
you.
the warm and inspiring opening remarks. It's really appreciate your valuable insight and your commitment to strengthening international collaboration in healthcare, medical innovation, and patient-centered care treatment. All right, ladies and gentlemen, we are now entering the first scientific session of today's International Oncology Webinar. The session 1 is entitled Minimal Invasive in Tumor Management, ERFA, and WA Indicators, Workflow, and Combination Strategies. Before the presentation begins, allow me to present the curriculum today of our first speaker. Mari kita sambut dengan hangat Dr. Kristanto Yuliarsa, spesialis bedah konsultan onkologi. Bisa ditampilkan untuk CV-nya. Oke, kita sambil menunggu tampilan CV, akan saya coba bacakan secara singkat. Beliau menyelesaikan pendidikan dokter di 11 Maret University atau UNS, kemudian melanjutkan pendidikan spesialis bedah umum di Universitas Gadjah Mada. Selanjutnya beliau menempuh pendidikan konsultan bedah onkologi atau bedah tumor di Universitas Udayana Bali, serta meraih gelar doktor di Universitas Gadjah Mada. Saat ini beliau aktif berkiprah di dunia pelayanan kesehatan di pendidikan, di antaranya di RSUD Dr. Muardi Surakarta, Fakultas Kedokteran UNS, serta tentunya Rumah Sakit Indrati Solo Baru. Hadirin yang kami hormati, dengan penuh hormat mari kita sambut pembicara pertama kita pada sesi kali ini, Dr. Kristanto Yuliarsa, spesialis bedah konsultan onkologi. Selamat pagi Dr. Yarsa.
Pagi, halo.
Ya dokter. Monggo dokter, pagi ini mungkin bisa menyampaikan materinya, pembukaan nih ya dok ya, materi pertama pada hari ini.
Okay, yeah, thank you for the participant, and then thank you for organizing committee to welcoming me as the first speaker. So, because the participant all are from Indonesia, so I will like to deliver my speech in Indonesia. Saya ini pembicara dalam bahasa Indonesia, saya takutnya nggak tersampaikan. Oke, terima kasih pada pagi hari ini saya akan memberikan bukan kuliah ya, memberikan sedikit sharing tentang minimal invasi tiroid di Indonesia ini. Jadi di Indonesia ini saya sudah mengerjakan tiroid sejak tahun 2006, kira-kira 20 tahun yang lalu. Sebenarnya teknik open thyroid surgery itu adalah very mature and safe. Jadi suatu teknik yang sudah sangat dikenal dan sangat mature dan sangat aman untuk mengerjakan baik tiroid yang ganas maupun tiroid yang jinak. Tetapi ternyata open thyroid surgery ini meninggalkan scar, terus kemudian ada hypoestesia, parestesia, terus kemudian ada komplikasi yang lain. Even though that kita bisa modifikasi, we can perform modification for all of the open thyroid surgery, that we can go to the fascia, yang paling sebelah kiri itu subfascia, and then itu subplatysma, terus kemudian ada match minimal access thyroid surgery, terus kemudian bisa menggunakan lateral approach thyroid surgery. Jadi kita bisa lakukan many kind of apa namanya surgery teknik, tetapi and then kemudian teknik open surgery itu juga di beberapa penyakit, beberapa disease, every of disease itu memang thyroid surgery itu merupakan suatu jawaban. Dan thyroid surgery itu, open surgery itu merupakan suatu apa namanya operasi yang tidak bisa digantikan. Karena beberapa itu membutuhkan expose, membutuhkan operasi yang bersih, dan membutuhkan operasi yang cukup radikal. Sehingga walau bagaimanapun teknologi berkembang, walau bagaimanapun nanti dia minimal invasif berkembang, open thyroid surgery itu tidak akan tergantikan. Nah, ini meskipun kita udah menjahit dengan bagus, dengan benang yang bagus, dengan teknik yang bagus, tetapi ada beberapa hasil yang tidak memuaskan, tidak memuaskan. Karena adanya keloid, ada kadang-kadang ada keloid, kadang-kadang ada scar. Terus kemudian, nah kita bisa nggak ini untuk operasi tiroid itu kita follow? Kan sekarang itu lagi zamannya invasif, minimal invasif era. Nah, minimal invasif era ini ada operasi tiroid nih yang apa namanya biasa kita kerjakan. Bisa nggak ini kita bikin minimal invasif tiroid era? Minimal invasif tiroid era juga sama dengan yang untuk perut. Nah, pada tahun 1980 itu sudah di operasi perut itu sudah menggunakan minimal invasif atau menggunakan endoskopi. Biasanya itu recovery-nya good, maksudnya cepat untuk balik lagi ke aktivitas. Terus kemudian good scar result, itu apa namanya, scarnya cukup minimal. Terus komplikasinya cukup minimal, biasanya waktu harinya untuk menginap di rumah sakit itu cukup minimal, terus kemudian nyerinya juga minimal. Nah, di sini yang biasanya memakai big incision atau irisan yang besar itu digunakan menjadi keyhole atau menjadi lubang kunci saja. Yang biasanya dilihat langsung itu menjadi menggunakan scoop atau menggunakan teropong atau menggunakan USG monitor. Terus kemudian ada menggunakan X-ray. Yang biasanya kita memakai tangan langsung untuk memegang jaringan, di sini kita menggunakan instrumen atau menggunakan robot. Nah, apakah aman untuk melakukan minimal invasif pada tiroid ini? Sebenarnya aman ya, karena dari persentase itu 90% itu adalah benign thyroid nodule atau jinak, terus kemudian hanya yang 10% malignan. Dari yang 10% malignan ini sekitar 85% itu adalah papillary, di mana papillary itu adalah tumor ganas yang tidak begitu agresif. Nah, kalau kita membutuhkan diagnosis yang cukup sulit biasanya pada kanker tiroid itu, biasanya kita bisa menambahkan dengan menggunakan core biopsi untuk diagnosis yang lebih baik. Nah, pada tahun 2012 kita di Indonesia ini sudah mulai melakukan operasi minimal invasif tiroid assisted atau biasanya menggunakan endoskopi untuk melakukan operasi tiroid. Nah, total endoskopi menggunakan tiroid ini kita biasanya lewat aksila atau lewat ketiak, lewat payudara, atau disebut sebagai ABBA. Terus kemudian pada perkembangannya dia berubah atau perkembangannya dia berkembang menjadi retroauricular, terus kemudian ada transoral. Di Indonesia sini terus terang kita kesulitan mendapatkan pasien karena pasiennya tumornya besar-besar di Indonesia karena ketakutan operasi, sehingga untuk pengumpulan pasien dari 2012 sampai 2018 itu hanya sebanyak 48 kasus. Nah, untuk teknik-teknik ini antara transaxillary, ABBA, retroauricular, dan robot ini kira-kira kepuasannya sama, terus kemudian nyerinya dan discharge dari hospital atau pulang dari rumah sakit itu waktunya sama. Nah, ini endoskopi tiroid, salah satu contohnya. Ini adalah tumor yang pernah saya ambil, yang terbesar adalah 5 cm. Di atas 5 cm saya kira cukup sulit, karena ruangannya cukup kecil. Terus kemudian pada waktu belajar itu di Vietnam, di Thailand itu dia menyatakan bahwa yang paling bagus itu adalah tidak lebih dari 4 cm. Terus ada komplikasi, ada rupture dari vena jugular vein, terus kemudian bisa ditangani dengan baik dengan klip. Sehingga ini sebenarnya cukup aman. Terus ini adalah tutfa. Tutfa itu adalah biasanya yang misalkan kita kalau belajar di Thailand, itu tutfa itu biasanya dari rongga mulut atau transendoscopic thyroid vestibular approach. Jadi sama sekali tidak ada bekasnya. Kalau sudah selesai nanti dia akan ditutup bagus tanpa bekas. Terus kemudian teknik yang ketiga ini berarti ya ketiga ya, dari payudara, ini dari tutfa atau dari mulut, yang ini dari retroauricula. Nah, ini biasanya untuk postoperatif komplikasinya itu ada injury juga sama, hipopaterisme, tapi sebenarnya irisannya cukup lebih besar ini, cuman dia memindahkan irisan itu berubah menjadi di belakang telinga. Sehingga untuk bekasnya cukup bagus, tidak kelihatan, secara kosmetik cukup aman. Nah, dengan mengikuti beberapa course, beberapa pendidikan, beberapa untuk teknik-teknik ini ternyata di Indonesia cukup sulit ya, karena tumornya biasanya bilateral atau kanan kiri, ukurannya besar, takut dengan operasi. Masih ada lagi permasalahan yaitu financial problem. Jadi kita tidak bisa melakukan operasi endoskopi ini dengan leluasa di Indonesia. Jadi apa sih yang selanjutnya yang harus kita berikan ke pasien nih? Apakah kita harus berhenti di sini atau kita harus ada solusi yang lain? Nah, ternyata ada heat ablation atau dengan ablasi panas, atau gampangnya tiroidnya dipanasi ya. Heat ablation itu bisa menggunakan radiofrekuensi, itu sejak tahun 98, ada menggunakan laser, terus kemudian menggunakan microwave, itu yang paling baru menggunakan microwave. Dari penelitian untuk microwave dan radiofrekuensi itu ininya sama, jadi tidak begitu berbeda jauh, efektivitas, komplikasi, efisiensi itu semuanya sama, terus tidak signifikan, sehingga untuk RFA dan microwave itu ininya sama. Untuk laser sekarang udah banyak ditinggalkan, terus kemudian sekarang yang masih jalan adalah RFA dan microwave. Microwave ini sebenarnya cukup simpel. Kita hanya perlu melakukan ditusuk jarum ya, jarumnya ditusuk dimasukkan, terus kemudian dia akan menghasilkan getaran sehingga menghasilkan panas pada jaringannya. Jadi yang panas bukan jarumnya, tapi yang panas adalah jaringannya. Setelah jaringan digetarkan sehingga menghasilkan panas, itu akan menghancurkan si tiroid. Jadi ini adalah invasive prosedur. Biasanya bisa digunakan kalau tumor yang gede-gede, lebih dari 5 cm, lebih dari 10 cm pun masih bisa, asal pasiennya kooperatif. Pasiennya bisa diam selama tindakan, itu bisa ini. Pasien sadar, bisa langsung pulang. Butuhnya cuma satu operator, satu pasien, satu asisten, sama satu sirkulator. Ini biasanya kalau tumornya besar itu 1 jam udah selesai. Nah, ini perbandingan dari operasi yang kemarin saya teliti pada waktu COVID. Itu ternyata kalau untuk operasi open itu blood exposure atau terpapar darahnya cukup banyak, sedangkan RFA itu darahnya cukup sedikit. Untuk endoskopi itu ya sedang-sedang. Terus untuk ukuran itu ternyata kalau open itu bisa bebas. Kalau endoskopi itu pengalaman 5 cm paling gede ya. Terus kemudian untuk RFA itu bisa ukurannya bisa bebas juga. Untuk open itu untuk keganasan bisa macam-macam. Untuk endoskopi ini untuk yang kecil aja. Terus kemudian untuk RFA itu yang low risk papillary, terus kemudian timnya itu ini 6 orang, ini 5 orang, ini cukup 3 orang. Terus time prosedurnya itu kalau open itu 90 menit, kalau endoskopi bisa 150 menit, kalau RFA itu paling 60 menit. Terus tidak perlu pakai ruang operasi khusus, tidak perlu oksigen khusus, terus kemudian bisa langsung pulang. Jadi untuk RFA ini cukup bermanfaat, terutama pada waktu COVID kemarin, sehingga tidak membutuhkan oksigen, tidak membutuhkan ruang rawat inap, pasien bisa langsung pulang. Ini adalah pengecilan, hasil pengecilan dari tumor setelah dilakukan RFA. Itu setelah 1 tahun, 1 bulan, 3 bulan, 6 bulan itu menurun drastis, terus kemudian 12 bulan. Ini adalah contoh-contohnya hasil-hasil dari RFA. Ini cukup bagus. Dari menonjol ini ternyata bisa hilang. Terus kemudian ini dari benjolan ini juga bisa hilang. Terus ibu ini yang cukup besar. Ini beliau takut dengan operasi. Terus setelah dilakukan RFA ini cukup mengecil, cukup signifikan walaupun pada waktu dikerjakan selama 3 jam. Kosmetiknya bagus, nyerinya kira-kira cuma 3 hari. Terus kemudian biasanya nyeri pada waktu menelan. Terus kemudian setelah 6 minggu dia mulai mengecil. Jadi tidak langsung mengecil memang, dia mengecilnya bertahap. Ini juga cukup bagus, minimal komplikasi di tangan saya, biasanya komplikasi kurang dari 1%. Ini benjolannya juga hilang, cukup bagus, rata. Jadi tidak perlu operasi. Nah, bagaimana dengan robotic thyroid surgery? Ini biasanya harus ada minimal surgery team atau ada tim untuk operasi minimal. Terus kemudian ini karena operator atau dokternya itu dengan pasiennya tidak berhubungan. Jadi yang berhubungan hanya robotnya saja. Itu minimal exposure. Jadi untuk infeksinya bisa sangat dibatasi. Terus kemudian bisa operasi dari jarak jauh. Bisa operasi dari jauh. Pernah ada operasi di Prancis dan Amerika, operator di Amerika. Terus kemudian ini sangat mahal. Sampai sekarang di Indonesia terutama sangat mahal. Terus kemudian membutuhkan waktu belajar yang cukup panjang. Jadi setelah ini di Indonesia kita punya ada beberapa, yaitu open conventional thyroid surgery atau tiroid terbuka, bedah tiroid terbuka. Terus kemudian yang kedua adalah endoscopic thyroidectomy, itu untuk tumor-tumor yang kecil, cukup kecil. Terus kemudian di antaranya yang lain adalah robotic thyroidectomy, kemudian yang lain adalah heat ablation, di mana kita biasanya di Indriati menggunakan radiofrequency ablation. Nah, bila kita analisis dengan bibliometrik, ini ya bibliometrik agak rumit ini. Jadi kalau kita lihat robotik itu pernah tinggi, publikasinya pernah tinggi tahun 2011, terus kemudian menurun, terus kemudian setiap tahun kira-kira ada 20 sampai 30 publikasi. Nah, yang paling banyak adalah universitas di Amerika, di Tulane University, terus kemudian setelah itu yang lain adalah South Korea. Nah, bila dilihat ini robotic surgery itu sudah biru ya, sudah biru artinya dia sudah penelitiannya sudah yang lalu-lalu. Sekarang apa sih? Sekarang yang lagi ngehit adalah tentang transoral atau melalui mulut. Nah, transoral thyroidectomy, terus kemudian transoral thyroid surgery atau robotik sendiri sampai sekarang sudah menurun, malah penggunaannya sudah menurun. Nah, untuk endoscopic surgery ini pernah mengalami lonjakan, yaitu tahun 2019, 2021 sampai 2023, kira-kira setahun itu ada 20 publikasi, paling banyak di Cina, terus kemudian yang lain adalah di South Korea atau Korea Selatan. Nah, bila dilihat dengan seperti ini, maka penelitian-penelitian yang baru itu yang kuning adalah quality of life-nya atau kualitas hidup dari pasien-pasien yang sudah dioperasi. Terus tiroid neoplasma, terus kemudian yang paling teknik yang paling baru adalah TUTFA, itu tiroid yang dioperasi melalui mulut yang paling baru. Nah, bagaimana dengan radiofrekuensi? Ternyata radiofrekuensi itu cukup bagus dan melalui lonjakan tinggi sejak tahun 2021 dia mempunyai publikasi 80 publikasi dalam 1 tahun. Terus kemudian dia ternyata cukup tinggi dan paling banyak adalah di Cina dan Korea Selatan. Terus radiofrekuensi cukup bagus, tapi dia sudah mulai hijau, jadi publikasi sudah mulai menurun. Yang paling banyak sekarang adalah publikasi tentang RFA pada tiroid yang kanker yang ganas. Jadi sekarang yang RFA yang paling baru adalah untuk tiroid yang kanker ganas. Nah, jadi untuk hipotesa atau conclusion-nya itu bahwa traditional surgery itu adalah fondasi. Jadi kita tidak bisa meninggalkan traditional surgery. Jadi kita harus melakukan harus melakukan pembelajaran mulai dari yang tradisional dulu. Setelah dikuasai, terus kemudian dokter bedah bisa mempelajari teknik-teknik yang baru yang lain, yang canggih-canggih untuk dilakukan untuk beberapa penyakit. Terus kemudian untuk penata laksanaan penyakit itu harus disesuaikan antara teknik dan jenis penyakitnya dan derajat penyakitnya sehingga bisa cocok gitu ya, bisa sesuai. Jadi tidak semuanya harus dilakukan dengan RFA atau tidak semuanya dilakukan dengan endoskopi atau tidak semuanya di open. Jadi tergantung dari pasien dan grade atau kanker atau penyakitnya. Ini adalah referensinya. Oke, dari saya kira-kira cukup sekian pagi ini. Thank you. Terima kasih. Kalau ada pertanyaan mungkin nanti bisa balik ke moderator. Terima kasih moderator.
Terima kasih Dokter Yarsa untuk penyampaiannya pada pagi hari ini. Luar biasa sekali informatif, memberikan kita bagaimana view terkait RFA ini, kapan digunakan dan lain sebagainya. Bahwa memang tidak semuanya bisa di RFA dan tetap kita lihat di lapangannya kira-kira seperti apa, apakah memungkinkan dilakukan RFA atau tidak. Dan banyak sekali juga ilmu-ilmu yang sudah dipaparkan oleh Dr. Yarsa, and we truly appreciate to the valuable knowledge and clinical experience you have shared with all of us today, especially regarding minimally invasive approaches in tumor management and integrated cancer treatment strategies. Okay, Bapak Ibu, we now move to the second session of today's webinar entitled LINE, Patient-Centered Care and Integrated Cancer Management. Dan pada sesi kali ini, materi akan disampaikan oleh Dr. Nadia Christina, spesialis onkologi radiasi. Namun terlebih dahulu izinkan saya untuk dapat membacakan secara singkat kurikulum vitae beliau. Mungkin bisa ditampilkan? Ya, sambil menunggu tampilan CV, di sini saya sepintas akan membacakan terkait CV dari Dr. Nadia Christina. Beliau merupakan spesialis onkologi radiasi yang saat ini menjabat sebagai Head of Radiation Oncology Unit di Rumah Sakit Indriati Solo Baru tentunya sejak tahun 2017. Selain itu, beliau juga dipercaya sebagai Secretary of Tumor Board serta Head of Cancer Registry tim di Rumah Sakit Indriati Solo Baru. Dan beliau juga aktif sebagai anggota Indonesian Radiation Oncology Society atau IROS. Beliau menyelesaikan pendidikan dokter di Fakultas Kedokteran Universitas Tarumanegara pada tahun 2010, kemudian melanjutkan pendidikan spesialis onkologi radiasi di Universitas Indonesia dan RSUPN Dr. Cipto Mangunkusumo pada tahun 2013 hingga 2017. Beliau juga aktif dalam publikasi ilmiah, salah satunya penelitian mengenai epidemiologi kanker di Indonesia yang dipublikasikan dalam GCO Global Oncology. Dengan pengalaman dan dedikasi beliau di bidang onkologi radiasi, kami harapkan sesi ini dapat memberikan wawasan yang luas mengenai pendekatan terapi radiasi modern yang terintegrasi dan berfokus pada patient-centered care. Selamat pagi, Dr. Nadia.
Selamat pagi, Dr. Novi.
Pagi, Dok. Terima kasih sudah bergabung.
Suara saya udah bisa kedengeran ya.
Iya, yes, betul. Monggo, Dokter, waktu dan kesempatan kami persilakan untuk menyampaikan materi.
Ini apakah screen sharing-nya sudah bisa dilihat?
Masih belum, Dokter?
Mungkin agak. Apakah panitia bisa ini bantu untuk sharing ininya, Dok?
Oke, bisa dibantu panitia?
Ya.
Yes,
Oke,
sudah
selamat pagi kepada direksi, Dr. Antoni Halim, Dr. Tirta, Dr. Yarsa sebagai narasumber, dan sejawat sekalian yang telah menyempatkan waktu untuk hadir di webinar pagi ini. Good morning to Mr. Sen Yan from Fosan, Prof. Yegang, Prof. Yang Chun. Nice to meeting you again, this time online, and hope you all have a wonderful day ahead. I'm Nadia, radiation oncologist from Indriati Hospital. Please let me share this topic in Indonesian. Hari ini saya akan sharing sebuah topik di bidang onkologi radiasi dengan judul Seamless Radiotherapy through Integrated Lineage Systems. Topik kali ini akan saya bagi menjadi 3 topik khusus. Sebagai pendahuluan, akan membahas tentang peran onkologi dalam penanganan penyakit kanker dan mengurangi beban kanker di Indonesia. Kemudian, bagaimana radioterapi berperan dalam bidang onkologi modern, terutama dalam penanganan pasien kanker yang jumlahnya terus meningkat. Selanjutnya, bagaimana alat radioterapi di unit kami, yaitu LINAC, meningkatkan akses pelayanan kanker dan hasil yang lebih baik untuk pasien-pasien. Next. Menurut data Globocan, data tahun 2022 ya, ini merupakan data yang dikumpulkan dari tahun 2018 sampai 2022. Kasus kanker di Indonesia menunjukkan jumlah yang meningkat signifikan dengan jumlah kasus baru penyakit kanker ternyata lebih dari 400.000 selama 5 tahun dan jumlah kematian akibat kanker lebih dari 240.000. Dapat dilihat dari sini 3 jenis penyakit kanker terbanyak di Indonesia, yaitu kanker pada pria ya, kanker paru, usus, dan liver. Sedangkan pada wanita, yaitu kanker payudara, serviks, dan ovarium, serta secara keseluruhan yang terbanyak adalah payudara, kanker paru, dan kanker serviks. Di mana jumlah ini menggarisbawahi kebutuhan yang urgent untuk adanya deteksi dini yang lebih optimal dan tentunya treatment yang lebih efektif. Next, dengan adanya treatment dan penanganan yang tepat dan cepat akan dapat meningkatkan survival, mengurangi komplikasi terhadap stadium lanjut, dan penyakit yang lebih kompleks serta hasil terapi yang lebih baik. Adanya beban kanker nasional atau cancer burden di Indonesia diperkirakan akan meningkat lebih dari 70% pada tahun 2050. Deteksi yang tidak tepat atau terlambat ini akan menyebabkan peningkatan jumlah kanker yang didiagnosis pada stadium lanjut meningkat. Oleh sebab itu, pentingnya screening yang lebih baik dan deteksi dini. Sedangkan dampak lain di bidang ekonomi itu dapat mempengaruhi tingginya biaya pengobatan tentunya, berkurangnya produktivitas masyarakat, dan dampak psikologis. Menjadi beban besar di sistem kesehatan nasional dalam hal ini termasuk BPJS. Diklik. Ya. Menurut data dari Huta sebelumnya, back lagi. Menurut data dari Huta Julu et al. Dan Arimbi et al. Dari Indonesian Journal of Cancer, ternyata lebih dari 60-70 jumlah pasien kanker di Indonesia itu datang pertama kali didiagnosis itu pada stadium lanjut, di mana hal ini tentunya akan meningkatkan beban kanker nasional. Next. Bidang onkologi di Indonesia sudah berkembang cukup pesat beberapa tahun terakhir ya. Seperti kita tahu bahwa penanganan penyakit kanker itu tidak serta-merta hanya satu treatment saja, tapi merupakan kerjasama dari multidisiplin ilmu atau bidang yang saling bermanfaat satu sama lain, yang yaitu misalnya pembedahan. Biasanya pembedahan merupakan terapi utama pada stadium awal, kemoterapi, radioterapi sebagai kombinasi atau adjuvan, imunoterapi, targeted terapi, maupun hormonal terapi. Radioterapi sendiri merupakan salah satu terapi penyakit kanker yang menggunakan sinar X dosis tinggi bertujuan mematikan sel-sel kanker. Tujuannya adalah menghancurkan sebanyak mungkin sel kanker dan meminimalisasi kerusakan sel-sel sehat di sekitarnya. Radioterapi berperan krusial dalam penanganan penyakit kanker, bahwa lebih dari 50-60% penderita kanker akan mendapatkan radioterapi dalam perjalanan pengobatannya. Next. Dapat kita lihat di sini, ternyata peran radioterapi ada di berbagai indikasi dalam suatu perjalanan penyakit kanker, bisa sebagai terapi definitif atau utama, seperti misalnya pada kasus-kasus kanker nasofaring, kepala leher seperti laring mungkin pada stadium awal, kemudian terapi adjuvan setelah pembedahan dengan tujuan untuk mengurangi kekambuhan lokal ya, ataupun bisa juga sebagai terapi paliatif, biasanya pada kasus-kasus perdarahan, nyeri, dan beberapa kasus penyebaran atau metastasis. Dan saat ini kita dapat lihat di gambar ini bahwa perkembangan teknologi radioterapi sendiri itu sangat berkembang pesat, di mana first line digunakan pada mulai tahun 1960 dan sampai saat ini sudah adanya yang paling terbaru dan mutakhir itu adalah proton terapi ataupun MR Linex yang merupakan kombinasi antara MRI dan Linex. Ini merupakan gambaran untuk lebih jelas apa sih maksudnya teknik-teknik radioterapi itu, kenapa tekniknya berbeda-beda dalam menyinar sebuah tumor. Bahwa kita lihat kalau 2D di sini, eh, penyeranan sebuah tumor itu jaringan sehat sekitar tumor masih bisa mendapat dosis berlebih. Namun jika kita memakai teknik yang lebih canggih seperti 3D atau MRT atau VMAT, jaringan sehat yang terkena tentunya akan lebih minimal dengan fokus ke jaringan kanker yang lebih maksimal. Next. Tentunya di Rumah Sakit Indriati, di mana onkologi merupakan salah satu unggulan, kami mempunyai unit radioterapi yang sudah ada sejak tahun 2017. Kita mempunyai 2 alat, Linex dan 1 CT simulator. Next. Next. Next lagi. Ini adalah alur pelayanan atau gambaran perjalanan seorang penderita kanker yang akan menjalani radioterapi, di mana tentunya pada awal akan berkonsultasi dulu dengan radiation oncologist untuk penjelasan diagnosis dan pilihan terapi serta efek samping. Kemudian dilakukan tindakan CT simulator dan imobilisasi untuk menentukan posisi pasien dan alat imobilisasi apa yang akan digunakan selama pasien menjalani radioterapi nantinya, serta CT scan untuk planning. Dokter radioterapi kemudian akan melakukan contouring, daerah mana saja yang mendapatkan radiasi dan dosis yang diberikan, lalu fisika medis akan melakukan planning dan menghitung dosis. Setelah ready, pasien akan memulai radiasi pertama hingga selesai 5 kali dalam 1 minggu sebagai dosis konvensional, dengan adanya evaluasi tiap hari maupun tiap minggunya. Dengan alur yang sangat kompleks ini tentunya staf kami sangat bervariasi bidang ilmunya. Di antaranya unit kami mempunyai 4 radiation oncologist, 4 fisikawan medis, 14 radioterapis, 8 perawat, 1 teknisi molding, 3 admin. Kami juga dibantu oleh ahli gizi, psikolog klinis, dan social worker atau relawan. Next. Ini adalah ruang CT simulator di mana pasien akan menjalani CT simulator ini sebagai tahap awal perencanaan sebelum dilakukan radioterapi. Dan ini adalah contoh-contoh alat imobilisasi yang digunakan pasien. Next. Untuk Linex-nya kita mempunyai 2 alat, yaitu Klinek AX dan Halcyon. Klinek AX yang kita punya sudah beroperasi sejak tahun 2017, di mana keunggulannya adalah flexibility dan versatility. Terutama lebih sering digunakan untuk kasus-kasus toraks, pelvic abdomen yang lapangan radiasinya luas, ekstremitas maupun kasus paliatif. Sedangkan untuk kasus-kasus Halcyon tipe B, keunggulannya adalah presisi dan speed, kecepatannya. Telah beroperasi sejak tahun 2022 sampai sekarang, dengan lebih fokus di kasus-kasus kepala leher, brain, breast, dan kasus-kasus pada anak. Next. Yang pertama, Linex Klinek AX ini, mungkin saya akan coba sharing lebih dalam lagi. Klinik AX ini dapat digunakan dengan berbagai teknik advance, tapi di unit kami kebetulan hanya 3D, MRT, dan VMAT saja. Belum bisa SBRT dan SRS. Mungkin nanti kalau suatu saat diberi kesempatan untuk upgrade alat. Dengan keunggulan lainnya, alat ini mempunyai multi-energi, yaitu 6 MV dan 10 MV, di mana dengan adanya energi yang lebih besar tentunya dapat menjangkau sel kanker yang letaknya lebih dalam. Dan adanya elektron beam untuk fokus ke kulit dengan dosis yang lebih baik, seperti contohnya pada kasus-kasus kanker kulit. Lapangan radiasi yang tentunya lebih luas, ini bisa sampai 40 kali 40 cm, telah digunakan di banyak center radioterapi di berbagai negara, dan merupakan linek yang presisi tinggi dan dapat digunakan pada area radiasi yang luas. Next. Linek kedua kami adalah Halcyon tipe B, dengan keunggulannya adalah sangat presisi dan cepat dalam treatment. Di mana Halcyon kami ini adalah alat di Indonesia adalah alat kedua setelah RSCM, dan saat ini sudah ada 14 Halcyon di seluruh Indonesia. Merupakan generasi terbaru linek, mempunyai single energy saja 6 MV, dengan gantry berbentuk ring yang bisa memberikan radiasi lebih cepat dan stabil. Mempunyai dual MLC, tentunya lebih presisi, adanya workflow yang otomatis, lebih minimal error, dan dapat terintegrasi CBCT imaging, KV, untuk evaluasi lebih akurat tiap radiasi. Namun, Halcyon di rumah sakit kami masih sebatas MV imaging, mungkin juga nantinya bisa di-upgrade untuk pelayanan yang lebih baik lagi. Next. Kalau tadi dari keunggulan-keunggulan Linek, sekarang kita bahas untuk keterbatasannya tentunya, walaupun tidak sebanyak keunggulannya ya. Klinik AX sendiri mempunyai waktu terapi lebih lama dari Halcyon. Setiap pasien itu rata-rata bisa 15-30 menit per pasien, dibanding dengan Halcyon yang hanya 5-10 menit saja. Untuk kerja operator manual, membutuhkan bunker atau ruangan yang lebih besar, dan kurang cocok untuk center-center dengan jumlah pasien yang banyak perharinya. Di unit kami, keterbatasan klinik AF ini tidak adanya OBI, yaitu untuk tadi proses CBCT imaging atau verifikasi yang lebih baik. Linek ini sudah digunakan hampir 9 tahun, di mana kita tahu bahwa lifespan Linek biasanya 10-15 tahun, tergantung pemakaian. Jadi klinik AX ini lebih fleksibel, terutama untuk kasus-kasus yang kompleks, namun butuh waktu yang lebih lama untuk pengoperasionannya, sehingga dapat mengurangi efisiensi jumlah pasien. Next. Sedangkan untuk Halcyon B juga tentunya ada keterbatasannya dibanding dengan Kleenex yang IX. Pada tahun 2022, rumah sakit kita menambah satu alat lagi, yaitu Halcyon ini, dengan single energy 6 MV dan tidak adanya electron beams. Dengan pergerakan coach yang minim, luas lapangan radiasi yang relatif kecil hanya 28 kali 28 cm. Jadi untuk kasus-kasus yang lebih luas seperti abdomen pelvic, toraks, dan meluas lebih dari 28 tentunya tidak bisa kita lakukan di Halcyon, tetapi di Kleenex yang IX. Dan Halcyon kami juga belum dapat melakukan teknik SBRT dan SRS sebagai teknik yang sudah advance. Namun dengan teknik MRT dan VMAT yang sudah unggul dan sangat bermanfaat untuk kasus-kasus pasien yang datang ke center kami. Halcyon didesain untuk efisiensi tinggi dengan jumlah pasien per hari lebih banyak dan lebih nyaman karena lebih cepat, tetapi tidak lebih fleksibel untuk kasus-kasus tertentu, seperti misalnya lapangan radiasi yang luas. Next. Ini adalah data kasus kanker yang ada di unit kami pada tahun 2025. Dengan terbanyak adalah kanker payudara sebanyak 39%, kanker serviks 16%, dan kanker nasofaring 7%. Next. Diklik semua. Ya, ini adalah contoh-contoh kasus yang kita tangani. Kebanyakan ini ada kasus yang inoperable, yang tidak bisa dioperasi, atau tidak atau kurang respon terhadap kemo, dan datang dengan perdarahan, nyeri, atau gejala lainnya yang bersifat paliatif. Dan kebanyakan kasus-kasus ini datang di stadium lanjut ya. Next. Ini adalah contoh-contoh planning yang kita lakukan di dua alat kita. Yang pertama ini di Klinik AX. Untuk kasus-kasus yang panjang luas, areanya lebih dari 28 cm, tentunya dilakukan di Klinik AX ini. Ini adalah kanker serviks dengan adanya keterlibatan KGP para aorta, sehingga radiasi cukup luas, lebih dari 28 cm, dan tentunya dengan menggunakan Klinik AX ini hasil juga optimal, efek samping minimal, dengan menggunakan teknik MRT untuk menghindari daerah usus dan organ-organ sekitarnya. Next. Contoh lain adalah karsinoma sinonasal, ini squamous cell karsinoma yang tadi. Ini kasus inoperable dan tidak respon kemo. Awalnya juga ada perdarahan, Untuk kasus kepala leher, kami lebih sering menggunakan Halcyon ya, karena prosesnya lebih cepat dan agar lebih presisi karena adanya organ-organ etris yang berdekatan seperti mata, lensa mata, saraf, dan sebagainya. Respon pasien ini sangat baik, tumor mengecil signifikan, perdarahan berkurang, dan kondisi pasien menjadi sangat lebih baik. Next slide. Yang berikutnya ini adalah kasus di pesawat Halcyon juga. Ini adalah kasus kanker payudara, kebetulan stadium awal, dilakukan dengan teknik hipofraksi, dengan fraksi yang lebih sedikit, yaitu 20 kali fraksi, dibanding fraksi konvensional yang biasanya 25-33 kali. Teknik ini dilakukan dengan dosis per fraksi lebih tinggi tentunya. Tapi efek samping yang dialami pasien sangat minimal, dan ini akan membuat overall treatment time, lama radiasinya, lebih pendek, serta akan lebih nyaman untuk pasien. Next slide. Kasus terakhir ini adalah kasus nasofaring yang termasuk 3 besar kasus terbanyak ya. Kasus nasofaring ini juga biasanya dilakukan di pesawat Halcyon. Mendapat radiasi sebanyak 33 kali dengan teknik MRT, SIV, dengan terapi adjuvan biasanya post kemo karena adanya residu tumor. Untuk kasus-kasus kepala leher itu terutama nasofaring, faring maupun kanker lidah atau sinonasal biasanya lebih unggul dilakukan di Halcyon. Kenapa? Karena lebih minimal efek samping, juga lebih cepat proses terapinya, dan pasien juga akan lebih nyaman tentunya karena selama penyiraman pasien harus memakai masker termoplastik. Next. Kedua linek kami rata-rata meradiasi 120 pasien per hari dengan mayoritas pasien stadium 3 dan 4. Tentunya lot pasien yang tinggi ini diimbangi dengan waktu tunggu yang pendek juga. Rata-rata pasien menunggu 1-2 minggu dari sejak konsultasi sampai CT simulator, tidak termasuk jika ada kerusakan atau trouble salah satu alat ya. Di mana di saat di daerah lain mungkin dengan alat yang masih terbatas dan load pasien yang tinggi, waktu tunggu bisa sampai berbulan-bulan. Dan kebetulan lebih dari 95% pasien kami merupakan pasien BPJS. Next slide. Ini adalah contoh bahwa ternyata di negara-negara lain itu ada guideline yang juga mengatur berapa lama waktu tunggu radiasi yang optimal dan terbaik. Seperti misalnya ini adalah contoh di UK, itu ternyata dari konsultasi sampai ke radioterapi mulai itu maksimal 31 hari. Sedangkan di Kanada sendiri ini 28 hari dari waktu tunggu konsultasi sampai radiasi pertama. Kenapa? Next slide. Kenapa waktu tunggu ini sangat penting ya? Karena untuk pasien-pasien stadium 3-4, seperti kebanyakan pasien-pasien di sini, tentunya terlalu lama itu dapat menambah keparahan penyakit dan juga gejala. Ini contohnya adalah sebuah penelitian yang ternyata tidak hanya waktu tunggu, ternyata lamanya radiasi, dari radiasi pertama sampai radiasi selesai, yang kita sebut dengan overall treatment time, itu juga sangat penting. Sehingga delay selama proses radiasi itu harus dihindari. Seperti misalnya trouble alat, kemudian compliance pasien-pasien yang mungkin tidak terlalu baik compliance-nya, maupun kebutuhan-kebutuhan pasien untuk peningkatan kondisi. Jika pada saat radioterapi ternyata seperti membutuhkan transfusi dan lain-lain, itu juga ternyata delay-delay tersebut mempengaruhi hasil terapi. Next. Kemudian ini adalah penelitian kedua, ternyata seberapa lama waktu tunggu radioterapi ternyata mempengaruhi planning yang harus diulang. Misalnya karena perubahan stadium, perkembangan kanker yang makin agresif, dan gejalanya memberat, dan sebagainya. Di sini disebutkan bahwa waktu tunggu radioterapi kurang dari 21 hari hanya memerlukan perubahan planning sebesar 3%. Tapi jika waktu tunggu itu menjadi 22-35 hari, perubahan planning bisa menjadi 11%, waktu tunggu 36-49 hari menjadi 26%, sedangkan kalau sampai hampir 2 bulan, itu perubahan planning tentunya sudah lebih besar, yaitu sebesar 39%. Sehingga mungkin pasien akan harus dilakukan CT simulator ulang, ataupun mungkin stadiumnya akan berubah, dan sebagainya. Next slide. Sehingga di unit kami pun Waktu tunggu dari CT simulator sampai ke radiasi itu dijadikan indikator mutu. Di sini menunjukkan bahwa 4 bulan di tahun ini ternyata kita mencapai 92%, menunjukkan bahwa prioritas pelayanan kami berkesinambungan dengan terapi pasien yang lebih maksimal. Next slide. Untuk kesimpulannya bahwa dengan adanya dua linek ini akan sangat membantu kami dalam melayani pasien yang lebih optimal. Untuk pemilihan kasus-kasus yang berbeda di masing-masing alat tentunya sangat berguna dan saling melengkapi keterbatasan alat masing-masing sehingga diharapkan dapat meningkatkan survival penderita kanker tanpa harus menunggu lama, mengurangi komplikasi dan mendapatkan hasil terapi yang lebih maksimal ya. Untuk kasus-kasus tertentu yang membutuhkan next slide. Untuk kasus-kasus tertentu yang membutuhkan teknik yang lebih advance seperti SBRT, SRS, tentunya kami rujuk ke rumah sakit lain yang dapat melakukan radioterapi tersebut. Dan unit radioterapi di Rumah Sakit Indriati diharapkan dapat berperan serta menurunkan beban kanker nasional dengan meningkatkan akses untuk mendapatkan layanan radioterapi lebih mudah dan cepat dan memberikan pelayanan yang terbaik dengan dasar utama kepedulian terhadap penderita pasien kanker ya. Mungkin itu dari saya yang bisa saya sampaikan hari ini. Terima kasih, saya kembalikan waktunya ke moderator, Dr. Novi.
Oke, terima kasih Dokter Nadia untuk penyampaiannya pada pagi hari ini. Sangat banyak sekali insight yang bisa kami dapatkan terkait linek begitu ya Dok ya. Oke, Bapak Ibu sekalian, kita akan memasuki sesi tanya jawab. Dan di sesi diskusi ini saya bisa lihat di kolom chat ya, sudah ada beberapa pertanyaan yang ditujukan baik ke Dr. Yarsa maupun ditujukan kepada Dr. Nadia. Kita coba jawab ya Dok ya, satu persatu. Mungkin yang pertama dulu untuk Dr. Yarsa. Ada pertanyaan, pagi dokter, saat ini tindakan minimal invasif semakin berkembang dalam penanganan tumor. Pada kondisi seperti apa RFA atau MWA menjadi pilihan terapi yang paling ideal bagi pasien? Jadi kira-kira kapan nih dok? Kondisi seperti apa sih yang RFA kayaknya lebih better atau MWA-nya lebih better begitu? Apakah sudah bergabung dengan kami Dr. Yarsa? Oke, sepertinya Dr. Yarsa masih belum bergabung ya dok ya. Saya ke Dr. Nadia dulu mungkin ya dok ya. Ada pertanyaan ini untuk Dr. Nadia. Bagaimana dokter menentukan kapan pasien membutuhkan radioterapi lainnya dibandingkan terapi lainnya dok? Terima kasih sebelumnya. Seperti yang dokter sampaikan tadi kan ada pasien yang diputuskan untuk dilakukan radioterapi nih dok. Kira-kira ada kriteria atau kapan sih dok terapi yang radioterapi lain ini dilakukan dan jadi pilihan dibanding terapi lainnya? Monggo dokter.
Terima kasih atas pertanyaannya. Yang tadi seperti yang saya jelaskan, radioterapi dapat ditempatkan di mana saja tergantung dari stadium penyakit kankernya. Jadi misalnya pada stadium awal, itu misalnya pada kanker-kanker kepala leher ya, nasofaring, laring, yang di mana tidak bisa dioperasi karena letaknya sangat dalam, seperti nasofaring misalnya, itu biasanya radioterapi menjadi terapi definitif sebelum dilakukan tanpa dilakukan operasi atau kemoterapi. Atau juga misalnya pada kasus-kasus tertentu operasi tidak bisa dilakukan, kemoterapi pun tidak respon, maka radioterapi dapat dilakukan untuk pilihan yang lebih aman. Juga di saat-saat paliatif, seperti misalnya pasien datang mau dioperasi belum bisa karena adanya perdarahan atau nyeri yang hebat dan sebagainya, maka radioterapi dapat dilakukan sebagai terapi paliatif terlebih dahulu. Nanti jika perdarahannya sudah reda atau sudah kering, tumornya juga sudah tidak nyeri lagi, nanti akan dikembalikan ke dokter bedah untuk dapat dilakukan operasi lanjutan. Begitu.
Oke, clear ya dok ya. Jadi memang tidak semua kondisi ya dok ya. Jadi memang ada beberapa kondisi yang kalau saya udah coba terapi yang lain, saya tidak berhasil dan lain sebagainya, atau tidak memungkinkan dilakukan terapi yang lain dan lain sebagainya itu tadi ya dok ya. Oke dokter, ada pertanyaan berikutnya. Pertanyaannya mungkin ini malah bertanya langsung ke salah satu layanan unggulan Indriati juga ya dok ya. Di sini ada pertanyaan, izin bertanya Dokter Nadia, bagaimana efektivitas pemeriksaan PET scan pada pasien yang menjalani radioterapi? Boleh nggak sih dok, sebenarnya kalau pasien yang udah
Ya.
masih radioterapi sebenarnya dilakukan PET scan mungkin ya. Jadi seberapa efektif mungkin PET scan itu bisa buat pasien yang menjalani radioterapi. Sebenarnya PET scan tuh buat kita scanning ya dok ya,
Mm.
bukan
Jadi
terapi ya
kalau
begitu
PET
ya.
scan itu
Mungkin dokter bisa
ya
menyampaikan.
bisa sebaiknya dilakukan sebelum radiasi. Itu untuk biar kita tahu stadiumnya dan penjelaran penyakitnya sudah masih lokal saja ataupun sudah lokoregional, sudah ke kelenjar ataupun sudah metastasis. Tetapi jika PET scan ini dilakukan setelah radioterapi, itu biasanya berupa evaluasi biasanya. Apakah penyakit kankernya itu sudah bersih ataupun adakah masih ada sisa atau residu yang membutuhkan penanganan yang lebih lanjut. Jadi tapi biasanya kalau PET scan dari radiasi atau kemo itu biasanya dilakukan 3 sampai 6 bulan setelahnya. Jadi memang tidak boleh terlalu dekat ya.
Oke, oke,
Gitu.
clear ya dok. Jadi memang satu buat scanning ya dok, yang untuk stadium dan lain sebagainya, mau lihat
Mm-mm.
penyebaran, kalau radioterapinya sendiri memang kita untuk terapi gitu ya dok ya. Oke, terima kasih dokter Nadia untuk jawabannya luar biasa sekali. Izin mungkin saya undang kembali dokter Yarsa. Apakah sudah bergabung dok dengan kami?
Ya, bisa dengar? Halo?
Iya, bisa dok, bisa
Bisa
sekali.
ya?
Iya dok,
Oke.
dapat dengar. Ya, izin dok, ini ada beberapa pertanyaan yang masuk untuk dokter Yarsa. Pertanyaan pertama, saat ini tindakan minimal invasif itu semakin berkembang dalam penanganan tumor. Nah, pertanyaannya pada
Ya,
kondisi
ya.
seperti
Betul.
apa RFA atau MWA itu menjadi pilihan terapi yang paling ideal bagi pasien?
Nah, sebenarnya terima kasih atas pertanyaannya ya. Jadi sebenarnya tiroid ini dari 100% itu 90% jinak. Sehingga gangguan sebenarnya apa sih? Apakah takut jadi ganas? Nggak ada masalah, nggak akan jadi ganas. Dan apa namanya, tumor jinak ini sebenarnya tidak ada gangguan yang cukup menonjol. Tidak seperti kanker yang terus kemudian dia bisa menginfiltrasi atau menyerang perjalanan napas, menyerang jalan makan sehingga tidak bisa makan, tidak bisa bernapas. Kalau tumor jinak ini kan berbeda. Ini dok. Jadi tumor jinak ini cuman gangguan sebenarnya kebanyakan cuman gangguan kosmetik saja. Jadi sehingga ada benjolan menonjol begini sehingga kalau ini terganggu. Kadang-kadang kalau tumornya besar itu bisa ada gangguan menelan. Nah, karena sebenarnya masalahnya hanya kosmetik, maka diselesaikan secara kosmetik. Sehingga untuk pasien-pasien yang jinak ini bisa dilakukan RFA atau MBA. Apakah tumor ganas bisa kan? Oh, tentu itu bisa. Jadi tumor ganas sampai saat ini yang jenisnya papiler itu bisa dilakukan RFA asal ukurannya tidak lebih dari 1 cm. Begitu dokter.
Oke, clear dokter untuk kapan menggunakan RFA dan lain sebagainya dibanding konvensional ya dok ya.
Ya.
Oke, mungkin ada berikutnya lagi nih dok. Berikutnya, mengapa teknik minimal invasif tiroid mulai dikembangkan sebagai alternatif untuk daripada konvensional? Kira-kira
Nah,
pasien
itu
dokter kenapa lebih milih
itu tadi
yang
satu yang paling ini bahwa sebenarnya tiroid itu lebih banyak yang tidak agresif atau kanker tiroid itu sebenarnya tidak begitu agresif atau banyak yang jinak, 90% jinak, dari 10% yang keras pun yang 80% itu tidak agresif. Nah, jadi jarang sekali tumor papiler yang agresif. Sehingga tumor-tumor ini lebih banyak membutuhkan penanganan yang tidak mengorbankan kosmetik. Nah, sehingga untuk penanganan yang tidak mengorbankan kosmetik, maka kita menggunakan minimal invasif. Tentunya untuk kanker-kanker atau tumor-tumor jinak atau kanker yang kurang dari 1 cm. Begitu, dokter.
Oke, clear ya dok. Ini juga di bawahnya ada pertanyaan kurang lebih sama, apa teknik kelebihan dan kekurangan dari teknik operasi tiroid yang konvensional tadi yang dijelaskan. Seperti yang dokter
Yang
tadi udah
jelas
sampaikan.
ini yang pertama adalah nyerinya. Rasa nyerinya mesti lebih kecil atau lebih berkurang daripada operasi konvensional yang dilakukan irisan atau insisi sepanjang 10 cm. Yang kedua adalah apa namanya bekasnya. Untuk skarnya itu ternyata lebih bagus pasien-pasien yang menggunakan eh, apa namanya minimal invasif karena irisannya cukup kecil sehingga apa namanya nyerinya bekasnya juga lebih minimal terus tidak perlu rawat inap terus tidak perlu bius dengan bius total, meskipun beberapa pasien menghendaki dengan bius total, tapi bisa dilakukan beberapa tanpa bius total, terus kemudian secara biaya secara keseluruhan jadi lebih kecil dan tidak lebih menakutkan. Jadi kalau banyak yang takut dok, ternyata banyak yang takut operasi karena di black gitu ya. Jadi dengan tindakan ini banyak yang jadi nggak takut. Ya, itu dokter.
Ya, oke dokter. Mungkin kita masih berlanjut ke pertanyaan berikutnya ya dok ya. Ini ada pertanyaan juga. Sebenarnya mirip-mirip nih dok. Pada pasien dengan kanker tiroid tipe papiler, bagaimana pengembangan tata laksana terbaru yang saat ini dianggap paling efektif dan untuk meningkatkan survival dan menurunkan angka kekambuhan? Bagaimana nih dok?
Oke, terima kasih pertanyaannya. Jadi untuk papiler ini ada beberapa papiler dengan tall cell varian atau papiler dengan follicular varian. Nah, itu biasanya yang tipe-tipe agresif kita masih menggunakan operasi. Operasinya dilakukan ismulopektomi atau pengambilan tiroid yang satu sisi. Tetapi untuk tumor-tumor papiler yang klasik atau papiler yang apa namanya yang tanpa jenis yang lain itu biasanya kalau ukurannya kurang dari 1 cm bisa kita lakukan dengan ablasi. Karena sebenarnya kanker tiroid papiler ini suatu kanker yang tidak agresif, tidak begitu agresif. Sehingga tumor kanker tiroid papiler ini bila kurang dari 1 cm bisa di-RFA, bisa lebih dari 1 cm, tetap kita lakukan operasi, tapi tidak semuanya, tidak kanan kiri, hanya satu sisi saja. Kecuali kanker tiroid papiler yang tall cell varian atau follicular varian. Itu dokter.
Oke, clear sekali dokter Yarsa, jelas sekali untuk jawabannya. Sekali lagi terima kasih dokter untuk kesempatannya pada pagi hari ini membantu untuk menjawab pertanyaan dari teman-teman sekalian yang sudah mengikuti acara webinar kita pada hari ini. Sekali lagi terima kasih dokter Yarsa. Mungkin saya berlanjut ke
Sama.
yes, terima kasih dokter. Ke dokter Nadia masih bersama kami dok.
Masih dok.
Oke, izin dokter ada satu pertanyaan terakhir nih dok. Pertanyaannya, bagaimana peran Linex seperti varian medical system Klinex 9 dan Halcyon dalam meningkatkan akses serta outcome terapi radioterapi bagi pasien kanker? Bisa dibantu dok?
Tentunya karena alat tentunya karena linek kita sekarang sudah dua, yaitu Klinex dan Halcyon, kita bisa terapi lebih banyak pasien dalam satu hari. Itu merupakan pasien dapat mendapatkan akses yang lebih cepat dalam mendapatkan radioterapi ya. Waktu tunggunya pun lebih cepat, 1-2 minggu sudah mulai radiasi. Kemudian alatnya pun canggih, jadi efek sampingnya juga lebih minimal. Jadi dengan adanya akses yang lebih mudah dan cepat, alat yang canggih, BPJS, pasien-pasien BPJS pun mempunyai teknik yang unggul, jadi outcome-nya pun lebih bagus, pasien lebih nyaman. Jadi itulah hal-hal yang dapat kita lakukan untuk meningkatkan outcome dan akses, serta nantinya mungkin berperan dalam mengurangi beban kanker di mungkin di Sukoharjo dulu ataupun di Jawa Tengah maupun bisa juga nasional. Gitu dong.
Oke, terima kasih dokter Nadia untuk jawabannya. Sangat clear sekali, sudah sangat jelas kira-kira bagaimana sih dia cara untuk meningkatkan akses serta outcome terapi itu seperti apa. Seperti mungkin tadi sudah disampaikan juga di dalam presentasi dokter Nadia ya. Oke, sekali lagi terima kasih kepada dua speaker Indonesian kami pada pagi hari ini, kepada Dr. Nadia dan kepada Dr. Yarsa. Terima kasih sudah berpartisipasi, terima kasih sudah membagikan ilmunya begitu pada pagi hari ini. Dan izinkan saya secara singkat untuk menyampaikan kesimpulannya dari kedua materi yang telah disampaikan. Kita bisa lihat bahwa pengembangan teknologi dalam penanganan kanker itu semakin mengarah pada terapi yang lebih presisi, minimal invasif, dan juga berfokus pada kualitas hidup pasien. Pada sesi pertama ini kita memahami bahwa teknologi RFA dan MWA itu memberikan pilihan terapi yang minimal invasif, lebih efektif dalam tata laksana tumor dengan mempertimbangkan tentunya indikasi pasien, workflow yang tepat, serta kombinasi dan modalitas terapi lainnya. Kemudian pada sesi yang kedua disampaikan oleh Dr. Nadia tadi kita juga belajar bahwa Linex itu memiliki peran penting dalam integrated cancer management melalui radioterapi yang lebih akurat, aman, patient-centered care tentunya, sehingga tidak hanya meningkatkan efektivitas terapi, tapi juga kenyamanan pasien selama menjalani pengobatan. Ya, sekali lagi terima kasih kepada dua speaker kami pada pagi hari ini. Dan ladies and gentlemen, thank you to all speakers and participants for the insightful discussion during the Indonesian session. We will now take a short break. Kita akan istirahat dulu, ya, approximately 15 menit before continuing to the international session. Dan pada kesempatan ini, kami juga ingin menyampaikan highlight mengenai strategic collaboration between Rumah Sakit Indriati Solo Baru dan Fosan Health Assistant Hospital yang kemarin sudah dikunjungi oleh Direksi Rumah Sakit Indriati Solo Baru ke China, begitu. Dan untuk sesi berikutnya, setelah sesi break, nanti akan dipandu oleh Dr. Tirta Putra. Beliau merupakan Wakil Direktur Rumah Sakit Indriati Solo Baru, dan beliau juga nanti di awal akan menyampaikan tadi highlight mengenai strategic collaboration between Rumah Sakit Indriati Solo Baru dan juga Fosan Health, begitu. Ya, kita masuki sesi rehat 15 menit mungkin dimulai setelah ini. Panitia bisa diputarkan mungkin video-video company profile dari Rumah Sakit Indriati maupun dari Fosan. Kita akan kembali 15 kembali. Terima kasih, selamat pagi. Saya Dr. Novi undur diri untuk sesi yang pagi hari. Terima kasih dan mohon maaf jika ada salah kata dalam melit acara pada pagi hari. Terima kasih.
Indriati Hospital, we believe that excellent healthcare begins with compassion, trust, and innovation. Standing with architectural grandeur, Indriati Hospital Solo Baru and Indriati Hospital Boyolali are designed to provide you comfort, safety, and international medical services. Our spacious and welcoming lobby reflects our commitment to patient-centered care, designed with advanced programs of air supply, return, and fresh air, providing a healthier environment. With 9 dedicated lifts categorized for public access, inpatients, emergency response, and hospital staff, we prioritize your privacy, operational swiftness, and infection prevention. As a child-friendly hospital, we provide dedicated play areas and children's gyms, ensuring a safe and joyful healing experience. Our seamless digital and online registration allows patients to access care easily and efficiently. At Indriati Cancer Center, we provide comprehensive and integrated cancer care. From expert consultations with our oncology specialists, advanced mammography and mammotome procedures, to state-of-the-art PET scan, chemotherapy, and LINAC radiotherapy. Our cancer center are also supported by emotional and psychological care through our cancer support group, because we believe that healing is not only physical, but deeper inward. In critical moments, every second matters. Time is muscle. Our heart center is equipped with air evacuation services, rapid emergency response team, ECG, and advanced patient monitoring, CT scan 128 slices, and to date, catheterization laboratories. Patients will be closely monitored in our fully equipped Intensive Cardiac Care Unit, ICCU, with a focus on one room, one patient. As a stroke-ready hospital, our fast response neurological team and ambulance are always at your hand. Powered by artificial intelligence-driven 1,5 Tesla MRI RTPA injection, DSA catheterization, microneurosurgery, comprehensive stroke rehabilitation, and home care services, we are committed to ensure your healing process. Our orthopedic and trauma center is adept at handling sports injuries with precision and minimal trauma. From rapid emergency response, advanced imaging, complete operating theaters, arthroscopy, to professional rehabilitation programs. Trusted by international sports organizations such as FIFA, AFF, and IBL, we support your comeback and your determination to become a champion. Enhanced by a green environment, spacious treatment rooms, and natural sunlight, we strive for your optimal recovery. Indriati Hospital, trust, professionalism, and compassionate care. Indriati Hospital, We work for a healthier Indonesia. At Indriati Hospital, we believe that excellent healthcare begins with compassion, trust, and innovation. Standing with architectural grandeur, Indriati Hospital Solo Baru and Indriati Hospital Boyolali are designed to provide you comfort, safety, and international medical services. Our spacious and welcoming lobby reflects our commitment to patient-centered care, designed with advanced programs of air supply, return, and fresh air, providing a healthier environment. With 9 dedicated lifts categorized for public access, inpatients, emergency response, and hospital staff, we prioritize your privacy, operational swiftness, and infection prevention. As a child-friendly hospital, we provide dedicated play areas and children's gyms, ensuring a safe and joyful healing experience. Our seamless digital and online registration allows patients to access care easily and efficiently. At Indriati Cancer Center, we provide comprehensive and integrated cancer care. From expert consultations with our oncology specialists, advanced mammography and mammotome procedures, to state-of-the-art PET scan, chemotherapy, and LINAC radiotherapy. Our cancer center are also supported by emotional and psychological care through our cancer support group, because we believe that healing is not only physical, but deeper inward. In critical moments, every second matters. Time is muscle. Our heart center is equipped with air evacuation services, rapid emergency response team, ECG, and advanced patient monitoring, CT scan 128 slices, and to date, catheterization laboratories. Patients will be closely monitored in our fully equipped Intensive Cardiac Care Unit, ICCU, with a focus on one room, one patient. As a stroke-ready hospital, our fast response neurological team and ambulance are always at your hand. Powered by artificial intelligence-driven 1,5 Tesla MRI RTPA injection, DSA catheterization, microneurosurgery, comprehensive stroke rehabilitation, and home care services, we are committed to ensure your healing process. Our orthopedic and trauma center is adept at handling sports injuries with precision and minimal trauma. From rapid emergency response, advanced imaging, complete operating theaters, arthroscopy, to professional rehabilitation programs. Trusted by international sports organizations such as FIFA, AFF, and IBL, we support your comeback and your determination to become a champion. Enhanced by a green environment, spacious treatment rooms, and natural sunlight, we strive for your optimal recovery. Indriati Hospital, trust, professionalism, and compassionate care. Indriati Hospital, we work for a healthier Indonesia. At Indriati Hospital, we believe that excellent healthcare begins with compassion, trust, and innovation. Standing with architectural grandeur, Indriati Hospital Solo Baru and Indriati Hospital Boyolali are designed to provide you comfort, safety, and international medical services. Our spacious and welcoming lobby reflects our commitment to patient-centered care, designed with advanced programs of air supply, return, and fresh air, providing a healthier environment. With 9 dedicated lifts categorized for public access, inpatients, emergency response, and hospital staff, we prioritize your privacy, operational swiftness, and infection prevention. As a child-friendly hospital, we provide dedicated play areas and children's gyms, ensuring a safe and joyful healing experience. Our seamless digital and online registration allows patients to access care easily and efficiently. At Indriati Cancer Center, we provide comprehensive and integrated cancer care. From expert consultations with our oncology specialists, advanced mammography and mammotome procedures, to state-of-the-art PET scan, chemotherapy, and LINAC radiotherapy. Our cancer center are also supported by emotional and psychological care through our cancer support group, because we believe that healing is not only physical, but deeper inward. In critical moments, every second matters. Time is muscle. Our heart center is equipped with air evacuation services, rapid emergency response team, ECG, and advanced patient monitoring, CT scan 128 slices, and to date, catheterization laboratories. Patients will be closely monitored in our fully equipped Intensive Cardiac Care Unit, ICCU, with a focus on one room, one patient. As a stroke-ready hospital, our fast response neurological team and ambulance are always at your hand. Powered by artificial intelligence-driven 1,5 Tesla MRI RTPA injection, DSA catheterization, microneurosurgery, comprehensive stroke rehabilitation, and home care services, we are committed to ensure your healing process. Our Orthopedic and Trauma Center is adept at handling sports injuries with precision and minimal trauma. From rapid emergency response, advanced imaging, complete operating theaters, arthroscopy, to professional rehabilitation programs. Trusted by international sports organizations such as FIFA, AFF, and IBL, we support your comeback and your determination to become a champion. Enhanced by a green environment, spacious treatment rooms, and natural sunlight, we strive for your optimal recovery. Indriati Hospital, trust, professionalism, and compassionate care. Indriati Hospital, we work for a healthier Indonesia. At Indriati Hospital, we believe that excellent healthcare begins with
treating patients like family, prioritizing virtue, pursuing excellence, friendliness, appropriateness, caring, and service. Foshan Fosun Chongqing Hospital has always adhered to this service philosophy, fully leveraging the courage and responsibility of its reformers. Daring to explore and innovate, the hospital has recruited top talent and made tireless efforts to improve access to healthcare and sense of happiness for the people in the Greater Bay Area. The Orthopedic Center, consisting of 5 subspecialties: spinal surgery, joint surgery, trauma orthopedics, hand surgery, and sports medicine, utilizes 3D printing and artificial intelligence to accomplish various complex surgeries for anatomical deformities of the atlantoaxial vertebra. Working with the neurosurgery department, the center has successfully performed intraspinal tumor surgeries in the upper cervical spine, rising to the biggest challenge of orthopedic surgeries. The Spinal Orthopedics Department has been designated by health authorities as the strongest hospital department in Guangdong several times. The Precision Oncology Center, a member of the Radiosurgery Society, offers diagnostic and treatment services such as genetic testing, genetic counseling, and international multidisciplinary consultations. With the introduction of Fosun's first M6 cyberknife and multiple new technologies, such as CAR T-cell therapy and electric field therapy, the center provides patients with cutting-edge, precise, and standardized treatment based on the principles of full cycle management, one-stop service, personalization, standardization, and precise diagnosis and treatment. The surgical center has extensive experience in the diagnosis and treatment of common surgical diseases, perioperative treatment and management of major surgical operations, as well as consultation, diagnosis, and treatment of tumors and complex surgical cases. It has developed the technical expertise focusing on minimally invasive surgery, ultrasound guidance, and rapid rehabilitation with the introduction of the next generation surgical robots. It has led the country in innovative surgeries such as fluorescence laparoscopy, laparoscope pancreaticodenty, cervical thoracic abdominal 3-incision radical surgery for esophageal cancer, and free greater omentum transplantation for breast reconstruction. Collaborating with Professor Wang Jian, chairman of the Chinese Urological Association, the hospital is making new breakthroughs in the field of minimally invasive urological tumor surgeries. The Women's and Children's Center has introduced advanced technologies and management practices at home and abroad, and capitalized on a high-end perinatal medicine center, a well-equipped gynecological center with strong expertise, and a comprehensive pediatric center to make itself a center with both excellent hardware and treatment-centered core competency. A full life cycle healthcare management platform for perinatal and general women and children's health is provided for specialties with different dimensions. The Heart Center is a major cardiovascular disease prevention and treatment center in Chongqing District, Foshan. It is a Foshan 14th Five-Year Plan key clinical specialty and is a national 5-center certification unit. In terms of technological breakthroughs, the center has successfully performed challenging procedures such as pulsed field ablation, renal denervation, closure of patent ductus arteriosus, transcatheter aortic valve replacement, and mitral transcatheter edge-to-edge repair. The Traditional Chinese Medicine Center brings together famous TCM experts from across the country and consists of clinical departments such as National TCM Practitioner Center, TCM Department, Department of Integrated Traditional Chinese and Western Medicine, and Rehabilitation Medicine Department. It offers distinctive TCM services that incorporate disease diagnosis and treatment, scientific research and teaching, and comprehensive health management. Big Health Promotion Center. The hospital has built a big health promotion center to support the Healthy China national strategy. Consisting of the Alma Laser Aesthetic Center, Health Management Center, and Yulan Health Club Premium Medical Center, it is committed to creating a new full life cycle health promotion model for families. The Promotion Center provides high-quality laser cosmetology services with advanced laser equipment and technology. The Promotion Center has also achieved significant success in reducing cardiovascular and cerebrovascular diseases by 70% with advanced blood purification equipment from Asahi Kasei Corporation. Foshan Fosun Chongqing Hospital focuses on clinical service, scientific research and teaching. As the first designated healthcare facility to implement the Hong Kong and Macau Medicine and Equipment Connect policy in Foshan, the hospital has taken the lead in introducing a variety of novel medications and devices of international repute, and it has applied many precise and cutting-edge medical technologies from other parts of China and foreign countries in Foshan to benefit the general public. Today, the hospital's laboratory has obtained ISO 15189 Quality Management System certification, demonstrating its internationally standardized testing capabilities. It has also innovatively introduced services such as Chongqing Hospital at Home, nursing home visits and specialized nursing outpatient clinics. Building on tradition and pursuing innovation in the context of healthcare's high-quality development, Foshan Fosun Chongqing Hospital has ranked first among non-public hospitals in China for many years by virtue of its great strength. The distinctive services that it has developed through innovation in response to the needs of the times will contribute to the creation of a new healthcare hub in the Greater Bay Area. Putting people first, treating patients like family, prioritizing virtue, pursuing excellence, friendliness, appropriateness, caring, and service. Foshan Fosun Chongqing Hospital has always adhered to this service philosophy, fully leveraging the courage and responsibility of its reformers. Daring to explore and innovate, the hospital has recruited top talent and made tireless efforts to improve access to healthcare and sense of happiness for the people in the Greater Bay Area. The Orthopedic Center, consisting of 5 subspecialties: spinal surgery, joint surgery, trauma orthopedics, hand surgery, and sports medicine, utilizes 3D printing and artificial intelligence to accomplish various complex surgeries for anatomical deformities of the atlantoaxial vertebra. Working with the neurosurgery department, the center has successfully performed intraspinal tumor surgeries in the upper cervical spine, rising to the biggest challenge of orthopedic surgeries: The Spinal Orthopedics Department has been designated by health authorities as the strongest hospital department in Guangdong several times. The Precision Oncology Center, a member of the Radiosurgery Society, offers diagnostic and treatment services such as genetic testing, genetic counseling, and international multidisciplinary consultations. With the introduction of Foschen's first M6 cyberknife and multiple new technologies, such as CAR T-cell therapy and electric field therapy, the center provides patients with cutting-edge, precise, and standardized treatment based on the principles of full-cycle management, one-stop service, personalization, standardization, and precise diagnosis and treatment. The Surgical Center has extensive experience in the diagnosis and treatment of common surgical diseases, perioperative treatment and management of major surgical operations, as well as consultation, diagnosis, and treatment of tumors and complex surgical cases. It has developed the technical expertise focusing on minimally invasive surgery, ultrasound guidance, and rapid rehabilitation with the introduction of the next-generation surgical robots. It has led the country in innovative surgeries such as fluorescence laparoscopy, laparoscope pancreaticodenty, cervical thoracic abdominal 3-incision radical surgery for esophageal cancer, and free greater omentum transplantation for breast reconstruction. Collaborating with Professor Wang Jian, chairman of the Chinese Urological Association, the hospital is making new breakthroughs in the field of minimally invasive urological tumor surgeries. The Women's and Children's Center has introduced advanced technologies and management practices at home and abroad, and capitalized on a high-end perinatal medicine center.
Okay, thank you. We are happy to welcome every participant to join this meeting. For this, the second session is an international session. Please let me introduce myself. My name is Dr. William Tirtaputra, as the Chief Operation Officer of Indriati Hospital. Ya, selamat pagi kepada seluruh peserta. Kami dengan sangat senang hati bisa mengundang para peserta untuk bergabung kembali. Kami di sini, Rumah Sakit Indriati. Saya izin memperkenalkan diri, saya Dr. William Tirtaputra sebagai Wakil Direktur di Rumah Sakit Indriati, Solo Baru. Dan kami sangat senang dengan adanya teman-teman di sini bergabung dalam acara kami. Dan semoga seluruh materi yang ada di acara ini bisa bermanfaat bagi kita semua untuk pengetahuan mengenai pengembangan daripada pengobatan kanker yang ada saat ini. So before we continue for the second session of international session by Professor Ye Kang and Professor Yang Chun, I would like to present the collaboration process within Indriati Hospital between Indriati Hospital and Fosun Changcheng. Ya, jadi sebelum kita memulai sesi kedua daripada International Session hari ini dengan Profesor Yang Chun dan juga Profesor Yegang, izinkan saya untuk mempresentasikan mengapa alasan Indriati Hospital melakukan kerjasama dengan Rumah Sakit Fosun Changcheng di Guangzhou, di kota Fosan. Oke. Ya. So let me introduce about this Oncology International Webinar. We want to introduce again about our hospital. This is our hospital, Indriati Hospital, which is located in Solo Baru, Sukoharjo, in the Central Java. We are already established since 2017, which is already on the land of 18,000 square meters, and with 27 floors and 182 beds. Ya, jadi Rumah Sakit Indriati adalah rumah sakit tipe C yang sudah akreditasi paripurna di Solo Baru, Sukoharjo di Jawa Tengah. Nah, rumah sakit kami berdiri di atas tanah 18.000 meter persegi dengan 27 lantai dan 182 tempat tidur. And next, we are going to present about our hospital, which is already system by cluster system. We separate each patient with their own diseases, so we separate. We really reduce the chance of cross infection in hospital. Ya, sebagai teman-teman ketahui di sini bahwa lingkungan rumah sakit saat ini banyak sekali penyakit yang bisa katakan cross infection, bisa cross infection dan ruang tunggu yang tergabung menjadi satu. Nah, di Indriati menjadi berbeda karena kami membuat semua sistem cluster di mana pasien yang menderita sakit gigi dia akan bergabung dengan pasien sakit gigi, pasien menderita tumor dia akan bergabung dengan pasien menderita tumor. Dan yang ketika dia menderita sakit paru, bahkan kita menyediakan satu tempat yang polikliniknya memiliki sistem negative pressure sehingga mencegah daripada penularan cross infection di rumah sakit. Jadi kita memastikan hospital patient centered care itu bisa berjalan di rumah sakit kami. And next we are going to present about our inpatient ward, which is consists of VVIP, executive, VIP, for the first class, second class, and the third class. Yeah, the biggest one is the VVIP, which is 72 meter square. Ya, ini adalah presentasi terhadap ruang rawat inap kami, di mana kami memiliki kelas VVIP, eksekutif, VIP, kelas 1, 2, dan 3, di mana yang ukuran terbesar adalah VIP dengan 72 meter persegi. Dan seluruh sistem kamar rawat inap kami sudah menggunakan air cooling system dengan chiller, di mana ada supply dan return, sehingga pasien diharapkan bisa lekas sembuh dengan natural sunlight juga dari jendela-jendela yang tersedia di kamar-kamar pasien. And it is our four of center of excellence. The first one is the comprehensive comprehensive cancer center. The second one is the Indriati Heart Center and the Indriati Brain and Spine Center and also Indriati Orthopedic Center with more than 100 specialty doctors, 8 subspecialty, and 35 consultants. Ya, ini adalah satu kebanggaan kami daripada Rumah Sakit Indriati memiliki 4 layanan unggulan, yaitu layanan kanker, layanan jantung, layanan otak dan tulang belakang, dan ortopedi dan traumatologi. Nah, dari sini kami memiliki lebih dari 100 dokter spesialis dan 8 subspesialis dan 35 konsultan. Yeah, and this is our facility for giving the best treatment to our patient. We have 10 operating theaters consist of 7 large or major operating theater and 3 one-day care operating theater. And all these operating theater already equipped with the pendant. So we are reducing the cable mass and also increasing the IPCN, the sterility level of the hospital, of the operating room. Ya, ini salah satu fasilitas unggulan kami juga. Kami memiliki 10 kamar operasi dengan 10 kamar operasi besar yang utama, dan juga kemudian ada 3 kamar operasi one day care. Dan semua kamar operasi ini sudah dilengkapi dengan alat-alat medis yang canggih dan juga menggunakan pendan sehingga tidak ada lagi kabel-kabel yang bertaburan di lantai, meningkatkan keamanan, keselamatan, dan kesterilitas daripada ruang kamar operasi tersebut. Ya. As presented before by Dr. Nadia, we already have 2 machine of Linec. The one is Kleinek IX and the second one is Halcyon. And 2 of these medical equipment supporting our radiation oncology for the best patient treatment. Ya, jadi memang di Rumah Sakit Indriati kami memiliki 2 Linec. 2 Linec ini merupakan salah satu terapi modalitas utama untuk terapi kanker, radioterapi. Jadi kami bisa mengerjakan ini semua dengan tujuan patient safety. And then the other we want to share is we have the PET scan, the first PET scan in Central Java and Yogyakarta. And it is the newest technology that we provide to support the healthiness of the Central Java residents. Ya, jadi salah satu teknologi terdepan yang terakhir yang kami launching adalah PET scan, di mana ini adalah memang alat pertama di Jawa Tengah dan juga Yogyakarta. Dan di sini sudah sangat-sangat bisa dijangkau oleh seluruh penduduk di Jawa Tengah dengan harga 12 juta. And before that, we want to share also our award from the Hospital Accreditation Institute. We already certified as Hospital Patient-Centered Care about last August, and we already pronounced that we can still taking care of the quality in just about 1 month ago. Ya, jadi bulan Agustus 12 Agustus 2025 kami sudah dinobatkan sebagai Hospital Patient Centered Care, di mana kami menjadi rumah sakit yang diberikan penghargaan oleh CARS, Komite Akreditasi Rumah Sakit, dan terakhir bulan lalu kami sudah tampil di CARS juga dan dinyatakan kami bisa mempertahankan daripada penghargaan tersebut. Ya. And next, I'm going to present about another our medical support and medical diagnosis equipments. The other is the MRI 1.5 Tesla with artificial intelligence, the CT scan 100 to 128 slices, for the ultrasound, digital mammography, vacuum bag score, mammotome, and bone mineral densitometry, dan also echo. Ya, jadi salah satu teknologi yang ada di Indriati, Jawa Tengah ini adalah kami memiliki MRI 1,5 Tesla dengan AI, jadi untuk pemeriksaan sangat-sangat cepat. Jadi kayak seperti pemeriksaan yang biasanya sekitar 30 menit, kita bisa potong waktu pemeriksaan tersebut sebagai hanya setengahnya saja. Jadi mengurangi rasa takut daripada pasien. Jadi diharapkan dengan ada AI ini mempercepat proses periksa, meningkatkan akurasi, dan juga meningkatkan patient experience, di mana pasien itu menjadi lebih nyaman. Jadi posisi kita bornya kira-kira 65 cm, jadi posisi tidak terlalu sempit. Jadi untuk pasien-pasien yang kira-kira beratnya mendekati 100 kilo atau bukan lebih, kita masih bisa melakukan MRI di tempat ini. Yeah, maybe the question is, why we go to China? We are doing the collaboration with Fosun from China. Maybe the question is why we need do collaboration with China. Ya, jadi pertanyaan utamanya adalah kenapa kita harus pergi ke Cina untuk mempelajari sistem-sistem ini gitu. Kenapa nggak cukup di Indonesia saja? Ya, the reason why we are choosing China is the advanced infrastructure, more advanced medical technology, the cost of living and other service is cheaper in Malaysia. Treatment costs are almost the same as in Indonesia. So therefore, patient will not be burdened by the cost of medical treatment. Ya, jadi memang kenapa alasan kami memilih Cina, jadi kami review daripada harga kurs dan sebagainya, ini waktu kami cek, itu harga kursnya semua bisa dikatakan lebih murah. Nah, jadi kita juga melihat bahwa teknologi alat medis di sana cukup canggih, dan ada beberapa alat medis yang belum ada di Indonesia, oleh karena itu kami berjalan ke Fosun untuk bisa diskusi dengan tim Fosun, untuk melihat ada progres apa yang bisa kita lakukan bersama-sama. Sehingga pasien bisa diharapkan ketika nanti datang ke Indriati dan menemukan ada penyakit-penyakit yang memang saat ini di area Jawa Tengah belum bisa tangani gitu, kita bisa akan lakukan referral, ya rujukan ke Posan. So this is our commitment of international medical collaboration as a sister hospital between Indriati Hospital and Fosun Health Hospitals. Jadi Fosun Health Hospitals. Ya, jadi ini adalah bukti kolaborasi kami antara Indriati dan Fosun Health Hospital, di mana mereka ada grup sekitar lebih dari 12 rumah sakit di seluruh China. Jadi mereka memiliki keunggulan masing-masing dari setiap bagian. Nah, saat ini kita mengedepankan perawatan kanker terlebih dahulu. Ya, so this is our ceremony at the Fosun Changcheng. Ya, why Fosun? Ya, why Fosun? Ya, kenapa harus Fosun? Ya, karena di sana mereka memiliki teknologi-teknologi robotik dan cyberknife yang tadi sempat disampaikan oleh Dokter Nadia bahwa selain daripada Linex, kita punya lagi teknologi cyberknife. Nah, itu ada di sana. So this is their hospital, Fosun Changcheng. Yeah. The reason why we collaborate with Fosun Changcheng is hospital is about 10 times larger than our hospital, and they have more technology than us. Ya, jadi alasan kenapa kita kerjasama dengan Fosun, rumah sakit mereka 10 kali lebih besar dari rumah sakit kami di Indriati. Jadi di sini kami bisa bekerja sama selain merujuk pasien agar pasien bisa mendapatkan pengobatan yang lebih maksimal, dan juga kami bisa sambil belajar dengan tim Fosun bekerja sama untuk training sehingga setiap dokter bisa meningkatkan kemampuannya semakin lebih baik secara international standard. So this is their technology. There's radio frequency, microwave, HIFU, cyberknife, and also they also have PET scan and cyberknife. And this is the CAR T cell, which is or will be presented later. Ya, jadi di Fosan itu mereka punya RFA, MWA, sebagaimana di Indriati, HIFU, dan CyberKnife kita tidak punya di Indriati. Mereka punya alat PET scan sama seperti di Indriati, tapi mereka di sana punya CyberKnife yang tidak dimiliki di Indriati. Dan di sana mereka sudah ada pengembangan tentang CAR T-cell, di mana ini bisa mengobati untuk pasien-pasien kanker seperti kanker darah. Ya, so where are we? Di manakah kita saat ini di Indriati secara di Jawa Tengah? Kita sudah bisa melakukan, so we can do the core biopsy, mammotome, RFA thyroid, LINAC, halcyon, and also PET scan. Jadi di manakah kita saat ini Indriati? Kita sudah bisa mengerjakan core biopsi, mammotome, RFA thyroid, LINAC, dan halcyon, dan juga PET scan. Jadi secara teknologi kita cukup apa namanya update. Walaupun ada beberapa kekurangan alat tadi. Makanya kita melakukan kolaborasi ini dengan Posan. Ya, ini core biopsy. So this is the core biopsy we are doing in Indriati. This is RFA thyroid as presented by Dr. Yarsa before. And as mentioned by Dr. Yarsa is really minimal complication. Ya, jadi ini core biopsy yang sudah dikerjakan di Rumah Sakit Indriati. Kemudian terapi RFA thyroid yang sudah dikerjakan juga di Indriati. Dan bahkan dikatakan oleh Dr. Yarsa sebagai presenter pertama, dikatakan ini sangat minimal komplikasi. Jadi kita mulai bergerak kepada teknologi medis yang minimal invasif, di mana pasien-pasien bisa mendapatkan quality of life yang lebih baik, sehingga pasien bisa menjalani hidupnya menjadi lebih baik. Jadi arah pengobatan kita sekarang sudah ke arah quality of life. So, as presented by Dr. Nadia, also this is the Indriati advancement. We have the CT simulator, the Klinex IX, and also the Halcyon. Ya, sebagaimana telah dipresentasikan oleh Dr. Nadia, jadi kita sudah memiliki CT simulator, Klinex IX, dan juga Linex Halcyon. Jadi di mana dengan alat-alat ini kita sudah bisa mendukung untuk pengobatan terapi kanker secara radioterapi, tadi pembedahan, Dr. Yarsa sudah bisa kerjakan. Terus kemudian kemoterapi sudah bisa dikerjakan Dr. Yarsa, radioterapi dengan Dr. Nadia. Jika membutuhkan RFA, radiofrekuensi bisa dilakukan dengan Dr. Yarsa. Jadi kita sudah menjadi tahap di mana kita memang sudah mengejar international standard daripada di dunia. Dan selanjutnya di Indriati, and we continue in Indriati also we have the PET scan. Yeah, this is the PET scan in Central Java and Yogyakarta with the 12 million rupiah. Ya, jadi di Indriati kita sudah punya nuclear medicine dan dengan PET scan, di mana ini PET scan tadi saya sudah sampaikan ada di Jawa Tengah dan juga Yogyakarta. Dan ini mempermudah akses, di mana pasien tidak perlu sampai ke luar kota atau bahkan luar provinsi lagi. Jadi mereka bisa cukup pergi ke Indriati untuk mendapatkan PET scan dengan harga 12 juta, dan memang di sini kita ada program dengan cicilan dengan perbankan, bisa jadi 1 juta per bulan. So, this is the summary of my presentation is Fosan Health Group collaboration. Focus on the first one is the patient-centered care. The second one is the unlocking the limitation of medical procedures in the city. And the third, increasing collaboration studies for medical advancements. Ya, jadi ini adalah summary dari presentasi saya, di mana kerjasama dengan Fosan ini memang adalah nomor satu adalah patient-centered care. Jadi kami mengutamakan di mana agar pasien ini bisa mendapatkan terapi sesuai dengan kebutuhannya. Jadi nanti mungkin akan dijelaskan nih perbedaan oleh Profesor Yang Chun, perbedaan antara Linex, Halcyon, dan juga dengan CyberKnife. Sehingga nanti kita bisa melihat bahwa kapan pasien harus dilakukan dengan Linex, kapan pasien dengan Halcyon, kapan pasien dengan CyberKnife. Ya, dan yang kedua adalah membuka batasan daripada prosedur-prosedur medis yang ada saat ini di area Jawa Tengah. Jadi kalau terutama di area Sukoharjo, Solo Baru. Jadi kalau misalnya ada beberapa rumah sakit yang belum bisa, atau teman-teman yang melihat ada potensi-potensi pasien yang membutuhkan terapi-terapi sebagaimana nanti dipresentasikan oleh Fosan, bisa menghubungi Rumah Sakit Indriati, nanti kami akan hubungkan dengan tim dengan Fosan. Ya, jadi dan juga yang ketiga adalah meningkatkan kolaborasi untuk pengembangan teknik medis. Jadi dengan kita kerjasama dengan Fosan, kami sangat mengharapkan di mana kami bisa menjadi sesuai dengan visi rumah sakit, yaitu menjadi rumah sakit internasional yang terpercaya. Ya, demikian presentasi dari saya. Okay, that's for my presentation. Right now, we are going to have the second session. This will be presented by Professor Ye Gang, MD, PhD, ASCO, AHH, hemato-oncology specialist from the Fosun Changsheng. And before we start, I will do the presentation about his curriculum vitae. Okay, this is the curriculum vitae of Professor Ye Gang, MD, PhD, ASCO, ASH, hemato-oncology specialist, which the educational background is the Vice Chairman Hematology Branch, Guangdong Busan Medical Doctors Association, licensed internist, hematologist, medical oncologist in USA, and his professional experience is the clinical chief of clinical officer, medical oncology and hematology Fosun Changcheng, and also the member of American Society of Clinical Oncology ASCO and American Society of Hemato-Oncology ASH. Please welcome Professor Ye Kang, and right now he will online from America. Am I right, Professor Ye?
Actually, I'm in China now.
Oh, already back to China. Okay.
Thank you. Thank you very much.
Thank you, Professor Ye. The time is yours.
Okay. Am I able to able to share the screen?
Oh, you want to share your screen?
Yeah.
Okay. Please tolong panitia.
Okay. So it makes
Yeah.
things a little easier.
Okay.
Give me just a few seconds, and then we can get started. Okay. Is that all right? The screen is okay?
Okay, Professor.
Oh, went back now. Okay. Thank you very much, Dr. Williams, for the wonderful introduction. And also thank you for the opportunity to share my my talk with you with our Indonesia colleagues at our Indriati Hospital. Excuse me. So also, I would also thank you, Dr. Navi and Dr. Nadia and Dr. Cristiano for a wonderful first part of the session. Their speeches were very educational and informative, but also makes my talk will be a little hard to follow then. Okay. Anyhow, I'm going to talk about CAR T treatment for refractory and relapsed large B-cell lymphomas today. And my talk will be, briefly 3 sessions with some background introduction for the lymphoma as well as the CAR T treatment. And second part will be mainly focused on the evolution of CAR T development as well as current practice based on the evidence, clinical trial evidence. And the last part, we share a little bit about the CAR T treatment experience at our center here in China, in Changchun Hospital. So first of all, diffuse large B-cell lymphoma is the most common non-Hodgkin's lymphoma subtype. That's the subtypes probably counts like based on current WHO standard classifications. It's about 100 subtypes, but more commonly will be over 30 subtypes. And we can see that's Chinese data from 2020, from 2011. That's like 10,000 pathologic samples. Among those, 40.8% were diffuse large B-cell lymphoma. So the new case in China is approximately 5.6 cases per 10,000 people per year. And fatality rate related to lymphoma was like 1.8 out of 10,000 people per year. Roughly, we can see that approximately 1 out of 3 patients with B-cell lymphoma would eventually die from it. So that's a huge challenge. And luckily, most people with the diagnosis of lymphomas had an excellent response to the first line of a treatment. And then the response rate is approximately 60 to 80%. And some of those who had an initial response might have relapse in the future. So roughly, the 5-year survival without disease is closely to 50 to 60%. In other words, still 40 to 50% of patients eventually will have the disease relapse and could die from it. And also studies from international cohort as well as the cohort in Chinese patients as well found that unfortunately by conventional salvage treatment for recurrent and refractory large B-cell lymphoma had very low response rate. ORR is about 26% in the international cohort and about 30% in Chinese cohort, with a complete response rate, a CR rate less than 10. And the median overall survival is approximately 6 months. So CAR T cells or chimeric antigen receptor T cells is a huge scientific breakthrough that was ranked top one in the Journal of Science back in 2013. And the CAR T treatment it brings up a huge hope for the lymphoma patients. And we can see that the T cells, when they try to attack the cancer cells, they are engineered, in vitro engineered by a car, almost like adding a GPS to those cells, and also will be proliferated and expanded in numbers so that when these cells be infused back to the patient, they could have a much larger number of the cells and with much higher specificity and targeting those cancer cells. And this is a famous story about a young girl by the name of Emily Whitehead. When she was only 6 years old, back to 2011, she unfortunately had a acute lymphocytic leukemia, and unfortunately did not have a good response to the initial conventional chemotherapy. That time, she was one of the first people who entered the clinical trial for CAR T treatment. And we can see here, that's April 2012, a little girl had this treatment. This is his father and the attending doctor. So she luckily had a complete response. And after that, she remains cancer-free. And each single year, she took a picture of herself. And for the 12 consecutive years. And last year in 2025, she was 18 years old and she entered University of Pennsylvania in the US as a freshman. And, you know, that was the hospital, that was the institute that she received her CAR-T treatment. So that's a very successful and a very touching story. Now we're talking about CAR-T treatment, and then there are several products that have been introduced, have been used already. And the one that we are using here is called Axicell or Yescarta. And mainly the mechanism of this is when we talk about this, we have this engineered CAR, and with the specific recognition of CD19 B cells for the tumor cells, and also this will have the co-stimulation pathway also taken into consideration, and that would be a CD3 and CD28, that pathway that's connecting with the normal B cells. So by this, we'll trigger these CAR T cells and to attack those cancer cells by releasing cytokines, by what we call the specific attacking and the lysis of the cancer cells and induce apoptosis and several other mechanisms. So the whole process is like this, briefly. First, that's what we call the autologous CAR T cells, meaning that first we collect the cells from the patient. And the procedure is very similar to, to that when people doing blood donation. We do leukapheresis and isolate this blood, mainly the mononuclear cells. Then the cells will be isolated, the T cells, and activating those T cells. And we'll be sending to the lab and doing genetic engineering of equipment, equipping with a CAR. And then also these cells will be expanded and proliferating and to certain numbers. And then the CAR T cells will eventually infuse back to the patient. The volume of this collection is approximately between 100 to 150 cc at the beginning. And after all this culturing and the in-lab manufacturing process, the final product sent back to the patient will be approximately 60 to 100 ml. And the whole process of this in vitro manufacturing would take approximately 2 to 3 weeks. So this Axicell had been approved first by FDA in the US in 2017, then in the Europe 2018, and in Canada 2019, in Japan 2021, and in China also 2021. So the indications had been expanded from more than 2 cycles of treatment with recurrent and relapsed disease to the second line of treatment. And also the disease had been expanded from purely diffuse large B-cell lymphoma to the other parts of the, like including primary mediastinal B-cell lymphoma and Burkitt lymphoma and high-grade lymphoma, as well as high-grade follicular lymphoma transformed into diffuse large B-cell lymphoma. We can take a look at the initial study called the ZUMA-1 study that was done quite a few years ago. That phase 2 study had this total patients number were 100 patients. Patients who enrolled in that study had at least had 2 previous lines of a treatment and then had disease progress. So we talked about this. The overall response were very low, and the CR rate only less than 10% in general and more conventional salvage chemo regimens. And with this X-cell treatment, CAR-T treatment, we can see the objective response rate was 83%. Among those, more than 60% had a complete response. And also, this is the survival data from this study, and that's on the left side, that's PFS, progress-free survival, and had 5.9 months. And for the median overall survival was 20.8 months. So remember that with a conventional way of doing this salvage treatment, less than 6 months of overall survival. So that's huge progress. Now, ZUMA-7 treatment was trying to push the treatment to an earlier stage, meaning when the patient, after failed to respond to the first line of treatment, or when they had an initial response but to the first line of treatment, but then had a relapse eventually. So that's what we call the second line treatment. So the response rate, overall response rate was still 83%. And then for standard of care, only 50%. And the CR rate was much higher, from like 65% in this group as compared to 32%, almost doubled. PFS was up to 14.7 months in this study. And OS, 4 years of OS was 54.6% with almost 4 years of follow-up, 46.2 months follow-up. So that at 4 years, with this follow-up date, OS was still not reached. So that's extremely exciting studies. That's a ZUMA we talked about, and there's another treatment, another clinical trial called the Alicante. Alicante study also was for those who had second-line treatment with X-cell. 3 months complete response rate, a complete metabolic response rate was 71%. That's very good, and the basic CR rate was 79%. General ORR objective response rate was 90% in this group. PFS was 11.8 months. The right panel is the median overall survival. Now we talk about Zuma 12. That's the phase 1 study that for the first line treatment for only those high-risk patients. High risk, their criteria was like IPI score was 4 to 5, or those double hit or triple hit lymphomas. And in this study, the CR rate was 86% with the first line of treatment, and CR rate, and even for those who had a double hit and a triple hit, which we all know that's considered very high risk patients, and with 90% of a CR rate. And for the 36 months, OS was 81%. That's very exciting data. And currently still ongoing treatment with expanding the Zuma 12 study. We talk about this will be a 1-to-1 randomly controlled clinical trial by using first line of CAR T treatment versus standard of care for high risk patients. High risk, they defined as IPI 4 to 5. Standard of care was could be using a regular R-CHOP or a dose-adjusted EPOCH-R. That's the treatment used by many hematologist oncologists for double hit or triple hit B-cell lymphomas. The primary endpoint will be an event-free survival. Second endpoint will be a PFS and overall survival as well. So this study is still ongoing, and we really will be excited to see the results. So how's this CAR T treatment fit into our current treatment paradigms in terms of diffuse large B-cell lymphoma? So currently, the first-line treatment standard of care still will be chemoimmunotherapy with regimens like R-CHOP or DA-EPOCH-R. And if the patient becomes primary refractory, meaning that they had a standard treatment, yet they don't have a good response, then what we call the primary refractory, or relapse, meaning that they initially had a response, but then had disease recurrent and progress. And then after first line of a treatment, we can, based on these studies, we could consider CAR T treatment. Or alternatively, we could do salvage treatment with chemotherapy with different regimens, including platinum-based, or like PD-1, PD-L1 immunocheckpoint inhibitors, or other BTK inhibitors in combination with chemo regimens, so on and so forth. And then, well, depending on if they have good response, consider autologous stem cell transplant. That's still the standard. If the patient is not a good candidate for autologous stem cell transplant by medical reasons, or just purely because they don't want to have a autologous stem cell transplant, then they could go to a CAR T treatment. Or even after disease progress, after autologous stem cell transplant, they still can consider CAR T treatment. many things, of course, need to be considered. We probably don't have too much time to talk to details at this point. The patients and the disease factors in determining who will be the good candidate for CAR T treatment. First of all, of course, the indications. For example, currently we don't have a approved or authorized CAR T treatment for T-cell lymphomas yet. And for patients, we need to have a basic condition would be good. For example, not severe cardiac conditions with adequate hepatic and renal functions and the others. And the third thing is, depending on what type of treatment they've been receiving, we need to have a period of time of called washout. For example, if we're using BTK inhibitors, the washout time will be a little bit longer, and some ADCs, like Polivy and others, a little longer. For some, chemo will be shorter. And so performance status, of course, and then the other thing would be financial concerns and others. And also, we're talking about there's very often we will need to have a bridging treatment. Bridging treatment meaning that we talk about 2 to 3 weeks time for the lab manufacturing process. And when we talk about this high risk of active disease, then very often they are very rapidly growing lymphomas. And then if leaving the patient without any treatment for more than 3 weeks, then you worry about disease progress, of course. Then we need to consider the regimens we use could be different regimens. So we talk about BTK inhibitors. We have also used chemo plus rituximab, or rituximab plus polatuzumab, which is anti-CD79B antibody conjugated with a drug that's a ADC treatment. That's very successful. And more currently, we're starting considering bispecific antibodies with anti-CD3 and anti-B cells like CD19, and using this for the regimen, for the bridging treatment. But of course, that would be after the cell collection, after cell isolation. And the radiation therapy is also a very powerful way to treat, to do the bridging treatment, especially for some Burkitt disease with large tumors. And we have a successful experience later on I can briefly talk about. And the severe adverse effects are quite a big concern for CAR T treatment. That's part of the reason we need to carefully select the patients and to define the candidates for the patient. And also the multiple organs could be affected with this treatment. Mainly, there are three parts of the adverse effect are major concerns. One is called the CRS, cytokine release syndrome, and one is called ICANS, or called immunotherapy-related CNS side effects, neurotoxicities, seizure, and encephalopathy. And also the third one would be the cytopenia and also others, cardiac and hepatic liver and hypotension, etc. So those are the factors associated with the severe AEs after CAR T. The host factor will be determined by how many lines of treatment the person had, and what was the current tumor burden is also very important important predictor. And the cell therapy, what kind of regimens we choose, and what cell product we choose, and the inflammation factors, and the CRS and ICANS we just mentioned. And we also need to have a comprehensive approach to try to monitor and control of the disease. What we do in my institute here is that we always inform our colleagues in ICU, in infectious disease doctor, in respiratory pulmonologist, everyone. And then in case anything happening, we could ask them to be involved quickly. And timing-wise, what we can see, that's the conditioning. We usually would need to have 3 days of chemotherapy, what we call the lymphodepletion, and then have the CAR T treatment, infusion, and then usually early phase will be 2 to 3 days with a cytokine release and chemokines and inflammatory cytokines. So somewhere between day 2 and day 7 will be a high peak of CRS and possibly ICANS as well. ICANS a little bit later part. And then that's usually for all the patients we need to be, we are going through the CAR T treatment. We need to consider to have at least 2 weeks of hospitalization for close monitoring after the infusion. We needed to have an early detection or early discovery of CRS or ICANS, and we need to work out and start a treatment quickly. The treatment will be mainly steroid and also the anti-IL-6 monoclonal antibodies and other supportive treatment. So the takeaway from this part is like when we talk about large B-cell lymphoma patients with refractory of a relapsed disease, could be as many as 40% of patients after first-line treatment. And the current conventional salvage treatment had a poor response rate and a poor overall prognosis. CAR T treatment has established a new standard of care, even for a cure. And the CAR T treatment for the bridging treatment and with the combination of the others, what we talked about, chemo and PD-1, PD-L1 inhibitors and BTK inhibitors and newer types of ADCs, etc. And the close monitoring and the prompt treatment of a severe adverse effect is crucial. So for the next few minutes, I would like to share with you some part of the experience that we've done here in our center. That's a 46-year-old lady who were initially diagnosed of high-grade B-cell lymphoma back to December 2020. Actually, even prior to that, she had felt enlarged lymph nodes in the neck by herself. And that in December 2020, she had a PET-CT that showed multiple enlarged lymph nodes throughout the whole body, and with the enhanced and much increased FDG uptake. And then had a biopsy confirmed that is a high-grade B-cell lymphoma with a MYC and BCL6 rearrangement. That's what we call the double hit. And that was a non-GCB type. If any hematologists in the audience, they know what we talk about. And that's a stage 4 for sure. IPI score is 3, that's intermediate to high risk, but based on the molecular panel of a double hit, that's definitely a high risk patient. And we can see that when first before the treatment, just at the diagnosis of in December 2020, she had a huge tumor load with enlarged lymph nodes in the neck, chest, and intra-abdomen as well. And the initial treatment she had was a traditional or standard way of doing RCHOP for 4 cycles. And the tumor load definitely had a decrease significantly, but did not receive a complete response. Had good or large PR, but not truly a CR. Then she went to have a maintenance treatment, but by the end of 2021, she had a disease progress. We can see large size of a tumor there. And after second line of treatment, and in August of 2022, the disease had actually progressed. And then had a third line of a treatment and still had quite a good size of a tumor remains in the body. And when she presented to us in September 2023, after 4 lines of treatment, still had a significant amount of tumor load in the body. So she otherwise was in a good performance status. She did not have a baseline comorbidity with a heart condition or and her hepatic and renal function were also adequate. So we feel she's a good candidate for the treatment, and we noticed that relatively large size of a disease in the left upper abdomen area. So this would be a good candidate for a bridging treatment with radiation. And the radiation, precision radiation treatment with the SBRT and other technologies is one of the very strongest and powerful weapon in our cancer center, which my colleague, Dr. Yang Jun, will be talking more right after me. So for this specific tumor, we eventually had this collaboration with our radiation with the radiation oncologists. We closely worked together, and then eventually had this part of radiation treated. And we can see that the lower panel was before the treatment, and then the upper panel was after treatment. We can see that after the radiation, and she received the CAR T treatment, and and 30 days after CAR T treatment, and get assessed by PET CT. And I'm sorry, that was 3 months after the CAR T treatment. We had a PET CT to evaluate the disease progress, disease response. And we can see that this area was completely went away. And this we can say that's combined with the radiation treatment, but also there are other places like this area was also had also some activity there, and also completely went away after the treatment. So for the very first time, for the more than 3 years after she was diagnosed of lymphoma, she had a complete response. And we had more successful cases. Currently, we've been treating, we have treated 13, we have treated treatment for 12 patients, and 13 patients is still ongoing now. And we have a very good team support. Our team, our center here is the very first one in Foshan had been designated as a CAR T cell treatment center, and the fourth one for the in Guangdong province. And we have a very strong team support with our nursing staff, with our multi-specialty physicians as well. Here's our team of a heme malignancy team, and which is something definitely I'm very proud of. And Dr. Yang Jun is the head of our whole cancer center, and he will talk more about our cancer center as well right after me. And we have a good MDT team as well. I thank you very much for your attention, and I'd be happy to take questions probably after Dr. Yang Jun's talk. And thank you again. Thank you very much.
Okay, thank you, Professor Ye. Thank you for your presentation. Once again, ladies and gentlemen, it's a pleasure to welcome you to this collaborative international exchange of medical information. Today's session is partnership between Rumah Sakit Indriati Solo Baru and Fosun Changsheng Hospital, which is a top tertiary rank A institution in China. Ya, terima kasih kepada Profesor Ye atas presentasinya. Jadi sekali lagi kepada Bapak Ibu hadirin sekalian, kami sangat terima kasih kalau atas kehadirannya dalam acara sharing knowledge ini dari antara Rumah Sakit Indriati Solo Baru dengan Fosun Changsheng Hospital di Guangzhou, di mana Fosun Changsheng Hospital ada rumah sakit tipe A yang sudah terakreditasi di China. So, the precision medicine is not just about new machines. It is about integrated case management and one-stop service philosophy that ensure every patient receive personalized roadmap to recovery. Ya, jadi pengobatan itu nggak cuma sekedar alat medis canggih saja, tapi memang kita harus integrasi dengan berbagai dokter spesialis, sehingga kita bisa berdiskusi, mengembangkan, sehingga pasien bisa mendapatkan terapi yang lebih baik. Okay, thank you, Professor Yegang, for that profound deep dive into the world of cellular immunotherapy. It's remarkable to see how we are now able to re-engineer within 2 or 3 weeks using the human immune system to tackle refractory lymphomas, which is about 40% of lymphoma cases of this type is lethal, which is around 1 in 3 patients may die. Ya, jadi terima kasih kepada Profesor Y, di mana kita bisa tahu bahwa dalam waktu 2-3 minggu kita sudah bisa membuat obat hidup dari tubuh kita sendiri yang bisa mengalahkan limfoma, di mana 1 dari 3 pasien itu kalau terkena limfoma tersebut tuh bisa meninggal. Jadi hanya cukup 2-3 minggu kita bisa mengobati pasien tersebut dengan respon rate yang tinggi, yaitu 83%. As the studies presented before, is the show response rate about 83%, with complete response rate about 60 until 86%. Is far better than chemotherapy. Ya, jadi kita lihat dari presentasi Profesor Y, di mana respon rate itu bisa 60 sampai 86% berhasil, dan itu lebih tinggi daripada kemoterapi pada kasus-kasus pasien limfoma tadi. So moving beyond the dead end of conventional chemotherapy for aggressive blood cancer, and this is a really good realization of the dream to be true. Ya, jadi daripada pasien-pasien kita memang ditemukan tidak bisa mengobati limfoma ataupun penyakit-penyakit lain yang seperti tadi dipresentasikan, bisa dari multiple lymphoma, B-cell, akut lymphoblastic leukemia, itu tidak bisa diobati, ataupun multiple myeloma, nah dengan CAR T-cell ini jadi bisa diobati. Yeah. Okay. While Professor Ye already showed us how we can target cancer cell at cellular level through biology and the immunotherapy, and now we are going to focus on target solid tumors with their extreme robotic precision through the radiation oncologist. Ya, jadi tadi Profesor Ye sudah cerita tentang kepada kita tentang gimana mengalahkan kanker melalui level biologi, seluler, dan sekarang kita akan belajar bagaimana menargetkan ke solid tumor dengan presisi dengan menggunakan robotik dan radioterapi. So it's now my pleasure to introduce Professor Yang Chun, MD, PhD, DIBR, IRO, PM, a radiation oncologist, a distinguished expert in medical physics with extensive experience from leading centers in United States. Kepada panitia tolong bisa ditunjukkan CV Profesor Yang Chun. For the committee, please show us the CV or Professor Yang Chun.
Sure, thank you. Thanks, Dr. Williams, for your introduction. I'm going to share my slides. All right.
Okay, Professor Yang Chun, thank you for your attendance, and yeah. So
Okay.
Professor Yang Chun will guide us about the CyberKnife robotic radiosurgery, which is very unique, and this is a good opportunity for us to know more about non-invasive cancer treatment. So Professor Yang, the floor is yours. Thank you,
Thank
Professor
you.
Yang.
Thank you again. And such a pleasure to discuss the robotic radiosurgery technology. And from the previous professor, I think Dr. Christine's wonderful presentation, I realized your hospital also has a very good, strong radiation oncology program. I had been doing radiosurgery for more than 25 years, and it's going to be my great pleasure to introduce my experiences. So we are going to have a little bit introduction about our Precision Oncology Center, where Dr. Ye is the chief medical oncologist. Then we're going to cover a little bit about the background about radiation and stereotech body radiosurgery, or we call it SBRT. Then we're going to cover CyberKnife technology, and we're going to spend most of the time to discuss clinical application of CyberKnife, and then we have a little discussion. So this is our precision center, and we founded this precision center with international standard. Right now, we have more than 130 team members. It's one of the foremost comprehensive cancer center in southern China. In terms of comprehensive, that means we are not just radiation therapy. We are not just chemotherapy. We have an international MDT consultation. We have a cancer screening by CT, robotic biopsy, radiation oncology, medical oncology, electric field therapy, TCM, minimum invasive surgery, PICC, infusion, VIP, etc. So we have very high standard technologies and high level clinical experts, and as well as active research and educations. So before I came back to China, I spent 20 years in the United States. I was head of medical physics for Alliance Oncology, where we supervise more than 50 linear accelerators and 18 CyberKnife in United States. We are the number one, the largest cyberknife chain in the world, not only in the United States but also in the world. So in the lower corner, we will see Dr. Lucy Brady and Dr. Jack Fowler. These two were the most famous and well-inspected radiation oncologists and medical physicists. And I was fortunate enough to follow them when I was younger and when I was just started my professional life. And later on, I was the board member for Radiosurgery Society. I was the chair of for physics committee for more than 8 years for Radiosurgery Society. And I read some guidelines in the United States in practicing radiosurgery, and spend most of my time on studying radiosurgery and precision radiation therapy. So about 6 years ago, I decided to move back to China after treating thousands of American patients. I realized what I learned in United States can be helpful to Asian patient, particularly when the Asian population is getting old quickly. So joined me, we have many known experts from China and also from American, including Dr. Tree. He is a very famous radiation oncologist in southern China, one of the most pioneering radiation oncologists in southern China. Dr. Ye, who just gave a talk, he practiced in the United States as a medical oncologist and hematologist for more than 30 years. And Dr. Han, as my chief radiation oncologist, he was trained in the United States as well. And Dr. Enming Wang, he has the most radiosurgery experience in China. He treated more than 25,000 gamma knife patients and more than 20,000 cyberknife patients in China. One of the most respected radiation neurosurgeon in China practicing, and one of the most experienced. So in our cancer center, we really combined our med-onc with rad-onc and also with the surgeons. So and right now we grouped our physicians based on the tumor site. So for example, for the breast and prostate patient, we have a radiation oncologist, a breast radiation oncologist, breast medical oncologist working with the breast surgeons together to offer our patient comprehensive breast-focused comprehensive cancer program. We have a breast and prostate, we have hematology, head and neck, and GI, lung, etc. So we really grouped our patient based on the disease site, along with the TCM and along with our PET-CT. As Dr. Ye mentioned earlier, we are very connected with international physicians. So every Tuesday morning, it had been 6 years on the road. Every Tuesday morning, we will see our Chinese patient with American doctors together via the Zoom. So that has established a huge reputation for us as a high quality MDT program with American doctors. And we would love to collaborate with Indonesian doctors to maybe provide MDT international consultation for your patient as well. So every Tuesday morning, we have a Zoom platform open. And we have a top-notch equipment in what we have is a large bore CT, PET-CT in our cancer center. We have our own DSA. We have our robotic biopsy navigation system. We have our Da Vinci system. We have our linear accelerator. We also have our robotic radiosurgery system called CyberKnife. So some background of radiation, and and you can see radiotherapy has evolved quickly and evolved long way since 1950s. And on the top is the older linear accelerators. In the bottom is the modern linear accelerator like a TrueBeam and the CyberKnife. And the machine has developed quick enough and precise enough that it can deliver multiple external photon radiation beam with 1 millimeter precision. typically when the radio surgery is different. Oops, what did I do? Sorry about that. So I switched the windows, so I kind of sorry about that. So I need to switch back to my presentation model. Okay, so basically, radiosurgery is different with radiation, conventional radiation therapy. We can deliver the treatment within 1 to 5 treatment. So we can finish all the radiation within 1 week instead of 5 weeks, 6 weeks, 7 weeks radiation. And every treatment, we give a very high dose. As such, the goal is to ablate the target. It's not to slowly kill the target. It's actually give a high dose to the tumor, and that we can have a very high chance kill the tumor with radiation. That's why it's called radiosurgery. Conventional radiation, and we will give 2 gray a day. This is a very classic treatment called a 4-box. In order to treat the red tumor, we will give 4 beams. So the tumor is getting 100% of radiation by intensity. At the same time, huge amount of tissue is getting 50% of what tumor is getting. Still, very largely volume of the tumor is getting tissue is getting high dose. Even proton therapy, it also has a challenge. Because it only deliver 1 or 2 field. A lot of the tumor is getting, even though the tumor is getting high dose, but a lot of tissue also get very high dose. So radiosurgery is different. In radiosurgery gives 100, maybe 200 radiation beams. So every beam with a small intensity, but when 100 beams come from everywhere and intersect and focused at the tumor gets really high dose. At the same time, tissue gets low dose. In this animation, the tumor only get 1 to 2% of the tumor dose, versus previously conventional radiation, the surrounding tumor could get a very high dose. So why it's important to give a high dose every day? Right now, with the conventional radiation, even with proton therapy, we give 2 gray a day. And the cancer killing power relationship is super linear with the daily dose. So what does that mean? So if we give a 2 gray a day, like the yellow line, then the 20 gray giving in 10 days, we kill this much cancer as represented with the yellow line. Okay, if we give 20 gray in 1 day as the red line, then 20 gray given in 1 day kills 2 times more cancer cells than the yellow line. So that's just the nature of radiation therapy. So typical application is treating early stage lung cancer. So if we give 60 gray in 3 treatment, which is 20 gray times 3, we have a 95% or higher local control. In conventional radiation, we give 60 gray in 2 gray per fraction 30 treatment. The local control rate is only 60%. So that's the power of radiosurgery. We give a higher dose every day, but we give less treatment. It's faster. It actually has more power. It also has more killing power to the cancer cell. So on the left is a classic treatment to treat the bone mets, to treat the bone tumor. And you can see not only the bone get irradiated, but a lot of normal tissue get irradiated. On the right side is a typical radiosurgery on the bone and the radiosurgery for the paraspinal bone mets. You can see with all the dose, most of the dose are focused on the tumor with a sub-millimeter precision, and the dose even curved in to spare the cord. And instead of 10 treatment in the left, on the right, we only need 3 treatment and has much higher local control. This is the lung patient I treated in Philadelphia many years ago. This patient had a surgery on the remote, so the left lung was removed. So the right lung had a new mass pop up. And the patient is too weak to have a surgery. So we will do radio surgery on this patient, and this patient survived another 3 years. So this is the comparison with the conventional radiation therapy on the left to radiosurgery CyberKnife in the center with the proton therapy on the right. So as you can see, the CyberKnife dose is much more focused on the tumor and spare the surrounding tissue. So this is the CyberKnife. So patient basically lay down on the bed, and the robot arm will carry the linear accelerate, which is very small, and deliver radiation to the tumor with from hundreds of the directions with 0.2 millimeter precision. And this is I'm going to play a video to you and to so that you can have some idea of CyberKnife technology.
System is the CyberKnife system is the world's first and only robotic radiosurgery system. This technology brings the benefits of radiosurgery to the treatment of tumors anywhere in the body. It provides a pain-free, non-surgical alternative for patients, including those who refuse surgery or have been diagnosed with surgically inoperable or complex tumors. CyberKnife treatments are done on an outpatient basis and do not require anesthesia or invasive stabilizing frames. Most patients can return to normal activities almost immediately following treatment. The CyberKnife system uses continual image guidance and computer-controlled robotics to precisely deliver high-dose radiation beams from virtually any direction with sub-millimeter accuracy. This unhindered mobility minimizes damage to surrounding healthy tissue and nearby critical structures like the spinal cord. The CyberKnife system is a dedicated robotic radiosurgery system. Unlike conventional radiation therapy, which delivers low-dose radiation in 30 to 45 treatments, CyberKnife radiosurgery delivers high-dose radiation in as few as 1 to 5 treatments. The CyberKnife system can be used as an alternative to surgery, unlike radiation therapy, which typically serves as an adjunct to surgery. Unlike other systems on the market, the CyberKnife system images continually throughout the treatment and automatically corrects treatment delivery for even the slightest tumor or patient movement throughout the body. This unique ability is important for treating tumors that move, particularly those in the spine, lung, liver, pancreas, and prostate. Unhindered by the clockwise-counterclockwise constraints of conventional gantry systems, the CyberKnife system's robotic mobility has significantly improved dose sculpting capabilities and conformal dose distributions.
So this video just tell you how the robot works. It's actually very powerful. So this one of probably the only technology that can move with the patient's breathing. When patient breathes or when patient moves during the treatment, the machine actually can follow the tumor and treat the tumor when the tumor at the same time. So so different with the other technology that with beam on and beam off with the gating. CyberKnife the only treatment that can track the tumor. So what does that mean? For example, when we treat the lung tumor, and the CyberKnife will follow the tumor's motion and only treat the tumor, spare the surrounding tissue. Versus in conventional radiation, when tumor is moving, the machine has to treat a much larger volume. So in this area, in these cases, that when we treat this red tumor, machines will damage 141 cc versus 65 cc on CyberKnife. So it's much less tissue damage in the CyberKnife technology. And this is the simulation of the small early stage lung cancer. On the left and the center are treated by linear accelerators. And on the right is treated by CyberKnife. You can see the CyberKnife damage to the tumor, to the tissue is much smaller. So this is the CyberKnife technology, which is really, I would say, one of the most advanced technology in radiation world, giving the highest treatment precision to the body, to the tumor in the body. So so as I mentioned earlier, CyberKnife can be treated for the brain and benign tumor, and the lung tumor, liver, kidney, prostate, pancreatic cancer, on the bone, etc. So the pretty much CyberKnife can be used for all the solid tumor except to the stomach, to the esophageal cancer and the bladder. To really to the hollow organ, because the CyberKnife is so strong, we worry about if we treat the bladder type of hollow organ tumor, it may burn the hole. So that's something we will be very careful about. So CyberKnife is very powerful treating the brain tumor. This is a typical case that we can use the CyberKnife to treat primary brain tumor and the most commonly seen brain mass and the brain surgical cavity. And this is some cases we can treat. We showing this is the diffuse the brain mets, and there are some single mets that we can treat either with the linear accelerator or with the CyberKnife. However, most commonly we try to use CyberKnife as much we can. So currently in our practice, we try not to do a whole brain radiation. We will try to do CyberKnife and first. So in our experiences, when patient had less than 10 tumors in the brain, we will do CyberKnife. And the patient typically have a treatment at 8 o'clock in the morning, finish by 8:30, and the patient could go back to work at 9 o'clock. So patient can go back to their own normal life on the same day. So our experience is right now, since chemotherapy is doing great job with target therapy, with immunotherapy, patient live really long time. So if we give a patient whole brain, patient probably could last 6 months. But if we give a patient CyberKnife, the patient can have a very good quality of life for another 6 months. If a patient has a new tumor pop up in the brain, we will CyberKnife again. So in America, I have a patient lives 15 years with me as a lung mets, and we treat patients 10 times in the last 10 years, and more than 30 tumors were treated. So it has been very, very effective in managing the brain tumor. And the CyberKnife can be treat orbital tumor. This is the patient I treated 20 years ago. This is the tumor pushing the eye, and we actually CyberKnife the tumor. At the same time, we spare the nerve in green. This is the first day. Patient have 5 treatment: day 1, day 2, day 3, day 4, and day 5. And the tumor actually shrink fast enough that on the day on the basically on the day 4, you cannot even see the tumor. You cannot even see the tumor well enough. So it's very effective. Oops. And we also use the CyberKnife to treat a benign tumor, including acoustic neuroma, AVM, pituitary adenoma, and meningioma. For this is on the left is a typical case for acoustic. So right now, the recommendation from MGH is for acoustic is doing radiosurgery first, particularly for the small 3 cm or smaller acoustic with hearing. We will prefer radiosurgery over surgery. On the right side is a functional radiosurgery, and this is a trigem neurology. With one treatment, we have 80% of the chance controlling the pain for 2 years. At the same time, Right now, we started treating epilepsy, Parkinson disease, and has been really effective as well. This just to tell you, CyberKnife is not only to treat a malignant tumor, we can also treat a benign tumor and also treat a functional disease. So for lung tumor, this is our publication in Philadelphia. We are going to talk about early stage. We're going to talk about the lung retreatment and the lung mets. This is a paper published in 20 years ago. At that time, there's no good drug. So if a patient had a surgery, patient have 60% survival rate in 2 years. At that time, there's no good target therapy, no good immunotherapy, please remember. So if patient's body is not healthy enough to tolerate a surgery, the patient have radio surgery, then patient has 2 years, 20% survival in 2 years. And then if patient is too weak, even have radio surgery, the 3 year survival is almost to zero. Is almost to zero, and without a surgery. So that's 20 years ago. But this gives you some idea on surgery's performance. So, so this is our experience treating CyberKnife in early stage lung cancer. Remember, that's 2007, 2011, 113 patients treated, 95 patients was evaluated. This all the older patients, they refused or medically unfit for definitive surgery. So patients are relatively older and weak. So we treated the 95 patients, only 3 patients failed. So we got a 97% of a local control. This is the patient's typical patient we treated. You can see that by doing this, we no longer need to remove the lobe or lumpectomy, and the toxicity is much lower, and the patient survival is about 60% as well. This is tell you for older patients and who cannot tolerate surgery, we still have almost 60% survival for 3 years, very much comparable with surgery. We are not the only one found that. Dr. Bob Timmerman and also reported in the RTOG study that they reported 60% survival for 3 years and 98% local control for 3 years. And this is European countries' data. European country also reports very impressive survival and local control. Their 5 years regional control is almost 90%, and distant control is 80%. So European country, they really separate the patient who can have surgery and the patient who cannot have surgery. If a patient is relatively young, healthy, who could tolerate surgery but received the CyberKnife, their 5 year survival is their 3 year survival is 70%, almost 80%. 5 year survival is 60%, and the older unhealthy patient is comparable. So very impressive data, and now we are looking at radiation retreatment. What happened is in United States, 70% of lung cancer patients, particularly stage 3 or 4 lung cancer patients, will receive a conventional radiation. And unfortunately, almost 50% of them will locally recur. And in the older time, when it recurs, the options are very limited. We cannot do surgery. We can only give savage chemotherapy, and the second radiation, conventional radiation, is also limited. However, we offered radiosurgery to this patient from 2008 to 2011 with 30 patients, medium dose is 30 gray, and what we saw is our crude local control is 80% in 2 years. And PFS is almost 60% in 1 year, 37% in 2 years. And also you can see the curve plateaued after 2 years. So some patients lived really long time. Some patients lived really long time. So toxicity is low. We have no grade 3 or 4 toxicity after this 30 patient. And this is a case study. A 57 years American African female represent the left upper lung tumor, 6 cm. A patient cannot tolerate radiation, conventional radiation, and recurred. And this the tumor recurred in the left upper lobe, and we give a cyberknife 5 treatments. And in 2009, the patient's tumor is controlled well until and the patient get a Tasivar and other chemos and other chemo for 2 years until patient had another tumor pop up in the right hilum. So this new tumor was not treated. So we give a high dose with a cyberknife at 50 gray in 5 fractions and get really controlled well. And the this patient basically survived another 2 years, and in 2014, so total 5 years. So conclusion for re-radiation for the lung, you can see that local control 80% and PFS 37% at 2 years, low toxicity. And so which tells us for an inoperable lung patient, even if patient had radiation and failed and still could survive with a cyberknife. This is the talk about the lung mets. So we have a 36 patient with 48 lung metastatic diseases. Half the patient are colorectal, the other half are breast, melanoma, renal cell, etc. And the actual survival is 57%. Local control is 90%. Only one patient has a grade 3 toxicity. This is our overall survival looks pretty good. A lot of patients survive. 50% survive at 3 years, and local control is very high, almost 90% in 3 years. And this is tell us it doesn't matter is what the pathology is. Even for sarcoma, for renal cell, melanoma, who were traditionally not sensitive radiation, still have very good survival and local control. So this is our liver case experiences. I will speed up a little bit, and we have a very high local control with the liver mets. And even for the patient who were heavily treated, patient had a surgery, had a taste, was heavily treated, and 49 patients with 62 tumors was treated, and 30 was evaluated. So we give a very high dose, and 70% of patients had a local control, and this is the overall survival. And so the mean survival after cyberknife, remember this is the heavily treated before with the surgery, with the chemo, with the TACE, and the patient minimum survival is 20 months. And the local control could be 80% if you give a high enough dose. And we are also we are one of the first group in the world treating prostate with a cyberknife. And so this is our data. Our data shows that at 5 years, our high dose cohort is almost 100% control, and the lower dose is 80% local control. So Stanford also reported their data. They are low risk at 7 years. Their low risk prostate is 95%, intermediate risk 84%, and high risk is 81%. This is the Dutch data with the 200 patients. Also shows excellent outcome, along with very low UI, GI toxicity, and the PSA declined to very low level and rarely rebound. And this is a summary of many studies. It's been heavily republished by the world, and most of the people report 99% or 95%, sometimes even 100% of local control for low risk, and very good local control for intermediate and high risk. and that's which is comparable with conventional radiation and also favorable to surgery. And this is a summary of the prostate, and almost every radiosurgery cases has 100% or 99% control for low risk and intermediate risk 95%. So for GYN cases, this is also my data in Philadelphia. Our group reported 42 tumors and with distinct metastatic disease and per-aorta metastatic disease treated. And medium, basically, this is our local control and also and the local survival. This is the case that the patient has a huge per-aorta and paraspinal mass and with this is the PET, and this is 3 years later, and we can see the tumor very controlled. And 3 years later, patient had another mass pop up, and we cyberknifed it again and controlled it. So with the cyberknife, we come to the discussion is this is the typical what we see in United States, a single brain mass, early stage lung. That would be wonderful if all our patients like this. However, we can see many other tumors. Patient has advanced disease, and as the previous our doctor mentioned earlier, in Indonesia, many patients had advanced tumor, stage 3, stage 4, nasty metastatic disease, and the cyberknife could control it. So this is the easy case to the brain. This is the difficult case that the tumor is the brain mass. This is the difficult case. Tumor not only in the brain mass, has multiple tumors in the brain. And this is the nasty tumors in the brain. And the cyberknife can do more, can do all. Left the single spinal mass, and we have almost 100% pain control with the cyberknife. In the middle is a complicated four vertebral cyberknife radiosurgery. On the right side is a very complicated spinal mass, spinal tumor that previously treated with the LINAC 3 times and retreated with the cyberknife. This is the easy lung on the left, difficult lung on the right. You can see the tumor is sandwiched in the middle sternum, and the cyberknife can really closely cover the tumor and treat it. On the left side is the easy liver. On the right side is a complicated liver. On the left side is the easy bone mass. On the right side is a complicated bone mass. So here I want to see compare with conventional radiation that only considering DNA damage. Right now is a new era of radiosurgery. With radiosurgery with high dose precision radiation, there's a multiple effect in control the tumor. We do not only cause DNA damage, we also damage the vessel, blood vessel within the tumor. And also we triggered, when we give a very high dose to the tumor, the tumor died quickly and release the neuroantigen. The neuroantigen will trigger the immune effect and cause the immunity to increase. And this is called abscope effect. So this is a immunomodulation. Basically, we give the rats. The rat had 2 tumors, one on the left, the other one on the right. We treated one tumor on the left. Not only this tumor died off, the other tumor on the right also shrinked. So this is called the abscope effect. So this is the long mass patient that we treated 5 years ago. The patient has a 6 brain mass in the brain, and including one in the brainstem. So we treat this one, and at the same time we give the 3rd generation TKI. Patient was lost conscious before treatment. In 8 days later, the tumor shrinked already, and on the 2nd day, patient come back conscious. And 1 month later, tumor shrink dramatically. 2 months later, tumor shrink so much, we give a little bit extra dose. That's a surprise number 1. Number 2 is other brain mass also shrinked. So we believe with the cyberknife or radiosurgery, we do not only kill the tumor, we also break down the brain barrier. As such, drug can easily get in, and also we improve the tumor's immune response. Last case to show this is the young patient with a malignant palloids. So the patient had a surgery and removed a 20 cm breast tumor, and 3 months later recurred and removed another 10 cm. Had a conventional 25 treatments, conventional radiation, and then the tumor continued to come back. Patient tolerant can still get the chemotherapy, target therapy, and immunotherapy, and still grow back. So patient lost the faith, and then patient disappeared for 1 year. 1 year later, the tumor grew back. Is dramatic, and so that we decided to give very high dose partial radiation therapy. So so the red is the tumor treated before, and the green is 1 month later. Remember, this is the tumor that failed chemo, failed the drug, failed the surgery, failed the conventional radiation. Almost nothing works for this malignancy. See, however, this two patient respond very well to the high dose radiosurgery. So only 1 month, the tumor shrink dramatically. And another surprise, which is the lung mass. There's 1 month later, the tumor in the lung mass also shrinked from 5 cm to 3 cm. The patient had no chemo, no drug, and no radiation to these metastatic diseases. This is the so-called abscope effect we believe that we triggered. And when we treat the tumor A, we release the neuroantigens. Neuroantigens improve the immune response of the whole patient body. Patient's own immune system respond well and start to act and attack the other tumor. So the tumor B also shrinked. Not only tumor A, but also tumor B shrinked. So we see this type of effect quite often with the high dose radiosurgery. However, we do not see that in conventional radiation. So my last slide is the conclusion. We believe cyberknife radiosurgery can be applied to most of the solid tumors with high treatment precision and fewer treatments. So 1 to 5 treatment, we can give a very high dose radiosurgery to the solid tumor. And the cyberknife may be able to trigger the immune response and improve patients' overall survival. Cyberknife can be considered for early stage, middle stage, and late stage patients who cannot tolerate or does not want to tolerate surgery. So I also want to mention we are going to have a high standard radiosurgery summit, and this year we are going to have a radiosurgery summit in Foshan in September 19th to 21, and we will have IAEA, we will have American doctors, we will have Southeast doctors, including Indonesia doctors from typical hospital from Indonesia coming, and we would love to invite all the doctors from Indonesia to join our radiosurgery summit, and particularly your radiation oncologist, your surgeons to join us. So thank you for your attention. And I know it's past your lunch time, but I really appreciate your time and your listening to my talk. Thank you.
Okay, thank you, Professor Yang Chun. It's okay. Our lunch time still about 30 minutes to go. So thank you, Professor Yang Chun, for master class in medical physics and clinical application. Ya, terima kasih kepada Profesor Yang Chun. Ya, tadi Profesor Yang Chun bercanda, mohon maaf udah ngelewatin waktu makan siang, tapi kita makan siang kan masih 30 menit lagi ya, rekan-rekan sekalian. So, Professor Yang has clearly illustrated in modern oncology how we deliver the dose is just as important the dose itself. So we are utilizing the superlinear or submillimeter killing effect to destroy the cancer cells more effective while protecting the healthy tissue. Jadi tadi Profesor Yang Sun sudah ceritakan tentang teknologi modern menggunakan daripada cyberknife, di mana kita bisa mengirimkan dosis radiasi sebaik mungkin dan seminimal mungkin, tapi dengan efek yang super linear, artinya yang semilimeter akurasi, sehingga pasien-pasien kita bisa mendapatkan treatment yang lebih baik dan juga jaringan-jaringan sehatnya itu semuanya aman, tidak sampai ada kerusakan di jaringan sehat. Nah, okay, right now we are going to have a Q&A session. As I saw that in the chat column, there's already some questions to both speakers. Maybe for the first one, I would like to ask to Professor Ye. Professor Ye, can you show us how much it costs for a CAR T cell treatment, especially for the patient in Indonesia? Ya, mungkin pertanyaan pertama kita akan mulai dengan Profesor Y, di mana kita mau bertanya kepada beliau, berapa biaya sih untuk CAR T cell, terutama untuk pasien-pasien Indonesia yang datang ke sana gitu.
Yeah,
Halo,
that's a
Profesor.
good question. Actually, there are two types of CAR T treatment. The one that I mentioned in my talk, mainly the data from that Excel, that's what we call the commercial one. That's being authorized and approved by Chinese FDA, as well as many other places like US, Japan, Europe, etc. So that the price for that is actually relatively high. In Chinese RMB, that's 1.2 million for the cell product. And if we add other part of the treatment, probably add up to like a 1.4, 1.5 million RMB total. So that being said, if we compare that price with the price in US for the same product, the US price is 350 USD for the cell products it's only. Not to mention the other part of hospitalization and all the other medical treatment. So if we compare to that price, the price that we have here is approximately somewhere like I would say between one and a half, between half to 1/3. So the US price is somewhere like between 2 to 3 times higher. So that's the one type. Then we talk about also there's what was called academic CAR T, meaning that those had not been approved by the Chinese FDA, but under clinical investigation. And that there are several products still under investigation at this point. So that the cost for that would be much less, much inexpensive. The cost for the cell products per se is theoretically should be free of charge. But of course, there are other parts of the treatment cost as well, like all the lab tests, bed, lodging, and other treatments. So I talked two types, and there's one small addition to that is more recently that's another commercially available, commercially approved by Chinese FDA. That's a China's product. X-Cell was originally made in the U.S. Then the China's company completely copied that. So that's all the technology, all the workflow, all the QC criteria, everything's exactly the same as the U.S. product. There's also recently a CAR T cell made in China, originally made in China, that has, I think the Chinese, the cost for that is about 500,000 RMB. So it's much, much less, even less than half of the commercial one, the previous one. Yeah.
Okay. Okay, thank you, Professor Ye. Jadi, so the conclusion is the price of the CAR T cell, if it's in China, it's about 1.2 until 1.5 million RMB. Ya, jadi kesimpulannya, teman-teman, di mana CAR T cell di China itu sekitar 3 miliar rupiah, di mana harga ini lebih rendah 2 sampai 3 kali. Artinya kalau di Amerika atau di tempat lain mungkin bisa sampai 5 miliar ataupun 6 miliar. Jadi memang di China ini memang lebih murah tapi bisa menjanjikan terapi, kualitas terapi yang hasilnya sama seperti di Amerika dengan standar yang sama. Okay, Professor Ye, thank you. I'll move to the next question to Professor Yang. Professor Yang, this question is from Dr. Melita. How does the treatment schedule for SBRT typically differ from the traditional radiation therapy?
Okay, so for SBRT, we typically give no more than 4 treatments a week. So we will do normally SBRT is 5 treatment or less. So so we will give a treatment once every day, right? We will Monday, Tuesday, Wednesday, Thursday, Friday, but we will try not to 5 days in a row. Maybe do Monday, Wednesday, Friday, Monday, Wednesday. That's it. Every another day. So because the dose is higher, so basically within 5 to 7 days, we will get all the treatment delivered, even 5 treatment delivered. For the smaller brain mets, we typically just give one day, one treatment. So basically, because the side effects very low, and we will give just 30 treatment, 30, I'm sorry, 30 minutes treatment in any day, and then patient will drive in by themselves. Patient can drive the car and after by themselves. So the side effects very low. So we don't worry about it.
Okay, thank you, Professor Yang. So the answer is about 4 times only, or all therapy only need for 7 days ya?
At most.
Ya, jadi ternyata bedanya SBRT itu dia karena dosisnya tinggi tapi presisi, jadi treatmentnya hanya butuh 7 hari, di mana mungkin fraksi-fraksi umumnya mungkin menggunakan halcyon itu mungkin ada butuh 25 hari, 25 fraksi, 25 hari, atau mungkin ada yang 35 hari. Jadi memang dia lebih pendek waktu terapinya. So, for the next question is from Dr. Arifani to Professor Ye. What are the most predictive laboratory parameter for severe CRS, and how we can differentiate between DIC and coagulopathy due to the CAR T? Professor Ye, please.
Excellent question. So I would suspect that this doctor was a hematologist. Anyhow, CRS and ICANS, or called immuno-related CNS side effects, are the 2 major severe adverse effects we've been watching, and also have been mostly studied in the medicine literature as well. So for CRS, we normally would do a panel of a cytokine detection that normally would include TNF, IL-6, IL-10, and a few others. We started with day 1, day 0, before the infusion of a CAR T, so that we will set a baseline. Yes, and after that we will do that depending on, we will do day 1, day 3, day 7, and depending on the patient's situation, we may need to do day 14 as well. Along with that, we will do CAR T detection as well, CAR T measurement. So how many CAR T cells in the body? Once they started growing, they started expanding in the body, in the human body, then that would be the time, more likely will induce this CRS and ICANS. So those are things we commonly use. And if we talk about CRS, the clinical feature would be most commonly fever and some degree of uncomfortable, and if to the degree that having cardiac issues, heart issues, or breathing issues with low oxygen, hypoxia, then that may need to start treatment with either steroid or more severe cases, steroid plus IL-6 monoclonal antibodies together. And that time, of course, we always do blood cultures routinely if the patient develop a fever and to rule out infection. And if the patient has a prolonged fever for two or 3 days, even with the treatment we just mentioned, we would add antibiotics anyway. So try to cover both. So that's the approach that we've been applying, and also that's what most experts recommended, and also being approved by those clinical trials. Because this time, during this period of time, it is also quite common to have low blood cells. If we remember that, I did not put too much details, but normally between day 5 and day 3, we would do 3 days chemo for lymphocyte depletion. So after chemo, now also after chemo will be after the infusion, so 2 to 5 days. That means 7 to 10 days after the lymphodepletion chemotherapy. So the cell numbers will be low. The neutropenia is very common. So we will need to have coverage of antibiotics anyway. So that's what we call this.
Okay,
Does
thank you,
that
Professor
answer
Ye.
your question? Yeah. If someone who does develop hypoxia with low oxygen or low blood pressure and without too much improvement by regular just uh, nasal oxygenation or just a regular hydration, and then the patient may need to go to the ICU.
Okay, thank you, Professor Ye. Actually, all attendants here, if you are willingly to do the online question, online Q&A, we are open for you to do the raise hand in your React tab, so we can know that you want to do the question by online, by live, so Professor Ye and Professor Yang Chun can see you. So in short, the answer from Professor Ye is we should check the cytokine panels regularly, and also the CAR T cells in the body. So we need to do the CAR T cells counting regularly also. Okay, and next we are moving for the next question for Professor Yang Shun. He come from Tohar. In the management of brain metastasis and irradiation of recurrent lung lesions, what are the key radiobiological advantage of cyberknife compared with the conventional fractionated radiotherapy?
Okay, great question. So, when we treat the brain, when we treat the recurred lung, think about that. The after the lung tumor had a conventional had a radiation before, all the radiosensitive cell already died off. And what recurred tend to be the tumor that's be more radio resistant. So that's number one. And also surrounding tumor or surrounding tissue already being irradiated, so already been damaged. So that's the challenge to re-irradiation for recurred lung. And in that case, in all the time, we will still treat with the conventional radiation because the surrounding tissue already being limiting and already being irradiated. So we can only give low dose and still cause very high toxicity. So the outcome is not that good with the conventional radiation for retreatment. But now with radiosurgery, the concept changed because we are so precise with 1 millimeter precision. So we give very high dose to the tumor and less dose to the surrounding tissue. As such, even the tumor become more resistant to the radiation. The dose is so high, we still kill the tumor anyway. So in other words, radiosurgery has more killing power to the tumor, but less side effect to the surrounding tissue because we give a higher dose in every treatment with that superlinear effect, so that we can comfortably to treat the to treat the tumor. So this sounds like a radiation oncologist from, he mentioned radiobiology. So radiosurgery has a lot more radiobiology effect than conventional radiation, as well as it can trigger the immune response better than conventional radiation. So conventional radiation tended to damage the immunity, but radiosurgery damage much less immunity, may also trigger the immune response. So there's two major difference in this perspective. So hopefully I answered your question.
Okay, thank you. Thank you, Professor Yang Jun. Yeah, there is some more questions about your explanation earlier from Tohar. He's like questioning about how about the tumor control probability, the normal tissue sparing, then ability to safely deliver high ablative dose from the
Yes.
previous irradiated.
Yeah, it's the same thing is remember CyberKnife's technology can track the tumor. When patient breathing, CyberKnife will track the machine will follow the tumor's motion. So it's also so precise. That's why the toxicity is much lower compared with other machine. If the toxicity is low, we can increase the dose to the tumor. That also increase the tumor control. So precision plays the key role in this situation.
Okay, thank you, Professor Yang Jun. So in short, it's like the radiation using the cyberknife is really calculated and measured so it can spare the healthy cells, right? So even though
Yes.
it's already radiated before, it will still spare the irradiated cells. Oke, terima kasih Profesor Yang Jun. Jadi singkatnya adalah karena cyberknife ini adalah alat yang canggih dan memang dia bisa mengukur dengan presisi jumlah radiasi yang diberikan, maka radiasi tersebut bisa menjaga daripada sel-sel yang sudah pernah kena radiasi sebelumnya agar dia tidak sampai mati. Demikian. Mungkin kepada teman-teman audiens, jika ada yang mau bertanya atau open cam, bisa dipersilahkan. So for all the audience, if you want to do the open cam to ask our speakers, we are really open for you to speak. Okay.
When we are still waiting for someone's asking the question, I just want to add a few more words to the previous question regarding the regarding the CAR T treatment and the side effects. So CAR T treatment is quite comprehensive and is needing very well organized and a very well trained team to work on that. And that being said, if we are able to just do diligently, meticulous monitoring of the patient, find the side effects early stage, and action promptly act on that, most people will do very well. For example, among the 13 patients that have been treated here in this center, we had one person was sent to ICU, and she just actually just last week and had a few days staying there and then came back. That person was actually had a combination of CRS, ICANS, and infection with pneumonia. So quite a difficult case, that one. But luckily, she went through all this and safely transferred back to the regular ward just the last few days. So, so it requires some specific training and some experience accumulations, but it's still very doable and still manageable side effects wise.
Okay, thank you, Professor Ye. There's also a question from Dr. Francisca Amelia. She's asking about which specific type of cancer is CAR T cell or AXI cells is primarily used according to your presentation. And also the other question is, what are the primary immunological toxicities associated with the targeted CAR T cell infusion? And what are the clinical signs of the early signs of the clinical in the patient?
Yeah. So for CAR T treatment, one we call the chimeric antigen receptor T cells. So that's been the X cell is one specific type targeting CD19 cells, meaning for B cell malignancies, like B cell type of acute leukemia, B cell type of lymphoma. That's very powerful. But there are also other types of CAR T cells. For example, we do have in our institute, we are authorized to do CAR T cells for multiple myeloma. That's the targeting antigen called BCMA for myeloma patients. So far, most of the authorized or commercially available CAR T cells are used successfully in hematological malignancies like lymphoma, leukemia, and myeloma. There are other CAR T cells under clinical investigation to target the solid tumors, such as a target antigen called Claudin 18.2 that's commonly in the GI malignancies, the stomach cancer or pancreatic cancer, and others. So that's currently under phase 2 clinical trial, but has not been approved yet. There are still several other academic CAR T or called clinical trial CAR T still doing a lot of research on the brain tumors and other types of tumors. So that's the CAR T. And the other part of the question was regarding the side effects, early stage of detection. And as I just mentioned, I want to just recap. So the patient commonly could have fever, chills, and sometimes the breathing will become more shortness of breath. And if not truly getting low blood pressure or truly getting hypoxia, then most likely it can be safely taken care of in the ward, in the regular hematologic ward. And for ICANS, for the CNS side effects, one little trick, little tip we've been using is try to train the patient to let the patient write down one single sentence. So simply just say name or good morning, doctors, or whatever. It is a nice day, whatever. So just simple words, but do the same thing every day. And if he or she is able to write correctly in his handwriting, quite okay. And sometimes, you can see 3 days in a row, 4 days in a row can write quite well. Then suddenly one day he or she could write just like 6 or 7 year old kid. Then that's a big alert for you to say, well, if that's the early sign of eye cancer. That's so just close monitoring. Anything unusual would be alert.
Okay, thank you, Professor Ye, for your explanation. I think there's all questions right now. Maybe the last question. Maybe this is from the Fosan side. Yeah, is there any international patient lounge specifically for the foreigners, maybe from Indonesia, that who wants to receive these advanced treatments? Do you have any workflow or patient flow, patient journey for the patient from Indonesia if they want to come to your hospital to receive this advanced treatment like a CAR T cell or maybe the cyber knife?
Probably cyberknife for more patients. Dr. Yang can say more about that. So far, we do not have a patient came from Indonesia to just for CAR T specifically, not yet. But we do receive a few inquiries from patients in Indonesia and Malaysia as well. Yeah.
So currently, we just started taking patients from Southeast Asia about 10 months ago, I would say 12 months ago. And now we have a lot of patients are interested at CyberKnife and CAR T. But obviously, CAR T is right now, CAR T is mainly used for blood cancer. But there's a lot more patients that are more suitable for CyberKnife. So we got a lot of inquiry, a lot of patients came in. They are very happy because it's a short treatment. It's only 1 week or maybe 7 days. The conventional radiation is 5 weeks, 7 weeks. So it's relatively convenient for the patient. And also for most of Southeast country patient, only when patient require more than 30 days, they need a visa. I think for Indonesia patient, if you stay in China for less than 30 days, you don't even need a visa. So the CyberKnife is a short treatment. That makes things much easier. And also side effects low, so they don't need to stay in the hospital for too long after treatment. So they can just go home. So I think if our patient went back to Indonesia, we would love to team together with you guys so that you can continue to take care of the patient when patient get back to Indonesia.
And also,
Okay.
we preferably, if we can set up an online consultation before coming here, would be the best, so that we will at least have at least a glance of the patient, how he or she is doing. So far, we pretty much accept most of the patients who have that kind of a wish to come to for the treatment, whether getting radiation, CyberKnife, or medical treatment. But we wanted to make sure that that person would be safe to have international travel, at least. And we do offer to pick up from the airport directly to come to our hospital, everything. So, and also if the patient has a specific diet request, for example, for halal food, everything that we can provide as well.
Thank you, Professor Ye and Professor Yang. So, jadi, so every patient that came to Fosun Changcheng, they can be picked up in the airport, and also they will prepare like maybe the hotel nearby had already collaborate with them. So make sure that every process is seamless ya. Jadi teman-teman di sini kalau memang ada pasien-pasien yang mau dirujuk kepada Fosan itu bisa nanti lewat dengan tim dari Indriati. Nanti kita akan manage bersama dengan tim Fosan, di mana nanti akan di sana ada translator daripada dokter-dokter di sana, sehingga tidak ada language barrier di antara kita, sehingga jadi setiap pasien yang datang di airport itu bisa dijemput dari airport, dan juga nanti akan bisa hotel-hotelnya pun langsung direservasi dari mereka juga. Jadi tinggal menjalani proses pengobatan dengan tenang, dan apalagi tadi Profesor Yang sudah mengatakan bahwa penerbangan dari Indonesia sampai ke China itu kalau memang menetap di kota Guangzhou itu dia tidak perlu bikin visa. Dia bisa ada visa free 30 hari. So all the attendants, the audience, we want to say that right now, flight from Indonesia to China, we can have a visa free for 30 days as long as you are only moving in only one city, one specific city. Right now, like Fosun Changsheng is in Guangzhou. So if we want to stay at Guangzhou, we don't need to make a visa. We can go back and forth direct to China and go back maybe through the third country. So, for all distinguished guests, colleagues, and fellow medical professionals, as we bring this international webinar to a close, it is clear that we have witnessed a powerful synergy between local clinical excellence and global technology innovation. And we already mapped out the complete ecosystem of integrated cancer management and complete integrated patient care. Our journey began with Dr. Yarsa, who is utilizing the RFA and microwave ablation for thyroid tumors, and then continue to the Dr. Nadia, who is focusing in Clinic IX and Halcyon, which is bringing the accessibility for the patient in Central Java, which is experiencing a tumor which it can be treated about 120 patients a day. So this proves that the world-class care in Indriati is a right move to bring Indriati to international class. Jadi pada international webinar ini kita bisa melihat bahwa sinergi daripada dokter-dokter yang sudah tersedia di lokal, yaitu Dokter Yarsa dan Dr. Nadia sudah menceritakan daripada Dokter Yarsa tentang teknologi RFA, yaitu minimal invasive for tumor-tumor tiroid, dan juga ada microwave ablation. Nanti bisa ke berikutnya jika dibutuhkan informasi bisa konsultasi langsung dengan Dokter Yarsa. Terus kemudian kita sudah berlanjut pada Dokter Nadia yang sudah presentasi tentang Linex IX dan Halcyon, di mana keberadaan Rumah Sakit Indrati dengan kedua alat ini sudah membawa aksesibilitas pengobatan radioterapi untuk pasien-pasien yang kita saat ini sudah berjalan 120 pasien sehari dan masih bisa ditingkatkan. Jadi kita menunjukkan bahwa memang Indriati sudah inline dengan tujuannya, yaitu menjadi rumah sakit berstandar internasional. Nah, kemudian tadi juga saya sudah sampaikan bahwa sudah terjadi kolaborasi antara Indriati dengan Fosun, di mana untuk patient-centered care. So, and next we are going to continue about further also proven by our colleagues in China. Professor Ye already giving us the illustration of revolutionary power of CAR T cell therapy, which is the response rate is up to 86%, which is really giving hope for the one who suffering lymphoma or multiple myeloma or also leukemia, which is previously they have no chance to live. And also from Professor Yang Chun is already demonstrate a mechanical perfection of the cyber knife, showing us that it can achieve a sub-millimeter accuracy only in 7 days for a complete treatment. Jadi kita tadi juga sudah dengar daripada Profesor Ye menceritakan tentang CAR T-cell terapi, di mana ini bisa memberikan harapan hidup atau keberhasilan terapi sebesar 86%. Jadi ini bisa membantu pasien-pasien kita yang jika mereka ada yang mengalami leukemia atau mengalami multiple myeloma ataupun limfoma yang sulit diobati, bisa nanti konsultasi dengan tim dokter kami di Indriati, lalu kita akan buka diskusi multidisiplin terapi. Jadi saya MDT itu biar bisa diskusi langsung telemedicine juga dengan tim daripada Fosun. Dan kemudian tadi Profesor Yang Chun sudah cerita tentang CyberKnife, di mana program terapinya cukup 4 sampai 7 hari, jadi sangat cukup banget waktunya untuk bisa pengobatan secara cepat dan tepat. So, for the takeaway today is simple, which is Indriati already provide the precision, speed, and accessibility, and targeting the managing the best quality of life of the patient. So, in Indonesia, mostly people fear that high-end technology is only for small elite. But in Indriati, we already provide with the machines and also the collaborative ecosystem for the patient-centered care. Ya, jadi kita bisa lihat sama-sama bahwa tadi di Rumah Sakit Indriati sudah disediakan alat-alat yang memang presisi, cepat, dan akurat. Dan untuk aksesibilitas bisa dijangkau untuk seluruh teman-teman yang ada di Jawa Tengah. Itu bisa datang ke Indriati untuk kasus-kasus kanker. Jadi kita bisa juga melakukan kolaboratif ekosistem. Jadi kita sudah kerjasama dengan Fosun. Kalau ada kasus-kasus yang sulit, kita bisa diskusi langsung dengan Fosun yang sudah berpengalaman di bidangnya dengan alat-alat yang canggih yang ada di sana. So, from the small precision surgical diagnostic of Dr. Yarsa, integrated radiotherapy from Dr. Nadia, also collaborative MDT with Professor Ye and Professor Yang from Fosun, we commit to provide a seamless journey for our patients. Jadi dengan diagnostik yang presisi dari Dr. Yarsa dan juga terapi daripada Dr. Nadia dan tim, dan juga dengan kolaborasi MDT dengan Profesor Ye dan Profesor Yang dari Fosun, kita Rumah Sakit Indriati komitmen untuk memberikan pelayanan journey yang terbaik bagi pasien kami. So, on behalf of Indriati Hospital and the organizing community, I would like to say thank you to Dr. Yarsa, Dr. Nadia, Professor Ye, and Professor Yang Chun for bridging the global insight to Solo Raya. To all of your attendance, before we leave this meeting, we would like to invite you to open cam so we can do the photo session from the committee. Please, everyone, we want to see you open cam so we can know each other, we can see our face each other.
I also want to give a compliment to Dr. William Tapachura, doctor. You are a fantastic moderator. And you also translate so smoothly and cross different specialties. You understand the hematology, you understand the surgery, you understand radiation. You did a really good job. I just want to give you that feedback.
Thank you,
Thank you.
thank you. The honor is mine. Thank you, Professor Yang Chen.
I echo that. Great.
Oke, mungkin dari panitia. Naim?
Baik, Dok. Slide pertama. 1, 2, 3.
We are going to take a picture first. We counting from 3, 2, 1. Smile. Okay. And then we continue for the next slide. Okay. 3, 2, 1, and smile. Okay, thank you everyone. Maybe for the last, from Mr. Bo. Mr. Bo is the representative of Fosun Health in Indonesia. Do you have anything to say to the audience?
Yeah, I think it's a very good and constructive webinar. And hopefully we can keep this going for the long run. And thank you everybody.
Okay, thank you, Mr. Bo. So now let us leave here with the commitment to continue the advancing into the new step, treatment of oncology, where precision meets compassion and where technology meets every patient who needs it. Let us move forward with the knowledge that the best technology in the world now is right here, accessible to everyone. Thank you and have a wonderful afternoon.
Thank you.
Thank you.
Hey.
Thank you. Thank you, Dr. Yarsa.
Thank you. Thank you, everybody.
Thank you, everyone. Bye-bye.
Goodbye.
Thank you, Dr. William. Good job.
Thank you, Professor Yang.